All right, everybody, welcome to the webinar. Welcome, everyone, and thank you all so much for joining us. This is South Texas Associates of Radiology. Today's lectures are presented by Jennifer Shuttler. We have two lectures for you today, 3 CEs, and we certainly do appreciate all of you. Before we start the webinar, please note, everyone, that you must be present for the entire webinar to receive your full 3 CE credits. Electronic attendance will be taken, meaning the time that you log in and the time that you log off is recorded electronically. So please ensure that you're logged in for the full session. We do get notifications if you have other windows open, so make sure all of those are closed because this does affect your inactivity score. During the presentation, if you lose sound, you can use the phone call icon to dial in with the provided number, access code, and PIN. This information is in your email. So you will listen on your phone and view the presentation on your computer. Now, this is only for if you lose sound. All attendee microphones are muted. You can use the questions box to send in your questions. All right, it is over now to Jennifer. She is standing by. And Jen, thank you so much for joining us first. Go ahead and introduce yourself and tell us a little bit of what you do. And right after that, you can start the first lecture. All right, Jen, the mic is all yours.
Excellent. Thank you so much for having me. I really appreciate this. Hi, my name is Jen. I am a nurse. I have been a cardiovascular nurse for almost 20 years, and I've been in the medical device industry now for almost 10. I work for a company called Cordis, which is a medical device company. Anyone from the cath lab would probably know us. But I've been in medical education now for, about 7 years. So currently I teach and train sales reps. I have been on the medical education side of things where I teach and train physicians and fellows. But my time spent in the hospital in acute care was entirely in interventional cardiology. And I worked in the cath lab for most of that. So what I have today is perhaps something many of you may not have ever heard of, but will become well aware of if you're not already. So we'll go through this discussion on INOCA. First and foremost, I have no financial disclosures other than being very, very nicely paid to do this seminar here. Again, I am an employee of Cordis, but these are my opinions and not of the company that I work for. I am also affiliated with UNC Rex Hospital, but none of their endorsements are in here as well. And any photographs, medical information, quotations were obtained through and used with patient permission unless otherwise noted. I have a lot of objectives. I'm not going to go through all these because you guys are going to learn a lot. In other words, this big slide is saying you are going to learn a lot about INOCA, what it is, how you can test for it, how imaging is important with that, the pathophysiology, mechanisms of how INOCA can produce myocardial ischemia. But this is a very heavy cardiovascular discussion because INOCA, as we'll see, is a cardiovascular condition. So to start, we're just going to go through some medical terminology that is important. So myocardium, myo means muscle and cardio means heart. So myocardium is the muscle of the heart. Epicardial is the outer layer of the heart. Epi means over. So if we talk about something that is epicardial, like an epicardial coronary artery, that is the vessel outside of the heart, the main vessels. Ischemia is a reduction in blood flow to that heart muscle. Angina is any pain that is associated with ischemia of that heart muscle. It can be chest discomfort, but it can also be pain or discomfort, or even sensations that patients may not describe as chest pain. Things like chest pressure, but a lot of people with angina or ischemia will say they have jaw pain or discomfort, shoulder pain, back pain. Sometimes it doesn't even seem cardiac, and it is. This is often accompanied by a shortness of breath, diaphoresis, fatigue, weakness, sweating, nausea, vomiting, the whole arena of symptoms. And then, of course, myocardial infarction, or MI, which is a heart attack. Super big pet peeve of most people who work in cardiology is the difference between a sudden cardiac arrest and a heart attack. So a heart attack, or an MI, is when you have ischemia with cell death, which that myocardium cell death, so heart muscle. You can have an MI without a sudden cardiac arrest. So sudden cardiac arrest is when you have a no heartbeat or an irregular ventricular rhythm that doesn't produce a pulse or blood pressure. So those are the two different things. It's just a pet peeve that TV shows and movies get wrong a lot. So let's talk a little bit about normal coronary arteries. Normal arteries, coronary arteries, originate from the aorta, which is the large artery that pumps blood or fills blood to the body. And it courses on the epicardial surface. So again, epicardial is the outer layer of the heart. So these major blood vessels feeding the heart muscle aren't located within the heart muscle at first. They lie on the outside of it. And they're a very thin layer of fat and connective tissue separating them from the underlying heart muscle. So they're just kind of laying on top of it. This is just another picture to show you have 3 main coronary arteries with 2 branches off of the aorta. The easier one to see is the right coronary artery that fills the inferior, sometimes the posterior wall of the heart. And then the left main branches off into 2 major epicardial vessels, the left circumflex artery and the left anterior descending artery, which people will call the LAD. So the LAD is the big bad one. This is what people refer to as the widowmaker if they had a proximal LAD stenosis, or even worse, a left main stenosis, because that LAD feeds the front wall of the heart. The circumflex wraps around and feeds the posterior or back wall. And sometimes between the RCA and the left circ, they connect together, and one may be dominant over the other. But this is just very, very brief discussion on the main epicardial vessels. Now, the important part that we have to talk about today is what an artery looks like. The artery has 3 layers: the intima, the media, and the adventitia. Tunica is just a root word for layer. So these are important. This is what differentiates an artery from a vein. That middle layer, that media in an artery, has a thick layer of smooth muscle cells. This is important. This is what we need to talk about. This as well as the intima. The intima is an inner layer. It's a single layer of endothelial cells. And the endothelium is what we'll talk about a lot today as well. In healthy endothelium, that provides a layer of signaling to the muscle underneath it. So it is a barrier. It allows some things in and out. And it also recognizes things like nitric oxide, which is a vasodilator, and endothelin-1, which is a vasoconstrictor. So it regulates that in order to tell the coronary arteries when to dilate more, say when you're exercising or stressed and need a little bit more blood flow. In dysfunctional endothelium, those endothelial cells don't work as well. Either that barrier has become penetrable, it's broken and allows things in that shouldn't go in or things out that shouldn't go out, or it doesn't sense things appropriately. In other words, it doesn't sense endothelin or nitric oxide, or perhaps it doesn't even produce them. So endothelial dysfunction is really important to INOCA, and we'll talk about that in a second. But first, we have to back up and we have to talk a little bit about those chest pain patients, those patients with angina. So this is silly, but I'm going to have you do it anyway. I can't tell if you're closing your eyes, but I want you to close your eyes. And what we're going to do is picture the typical chest pain patient. If you've ever taken care of a patient with chest pain, either in an emergency room or in the hospital or in a clinic, I want you to think about what they look like. How old are they? What other conditions do they have? What do they do with their time? What are their hobbies? What is their body shape? Again, physically, what do they look like? And do they look healthy or unhealthy? Now, probably most of you pictured older folks, maybe an older gentleman who perhaps is a little obese. Maybe he's eating McDonald's, smoking a cigar, not checking his blood sugar like he should be doing. But what's really interesting with INOCA, but with other coronary diseases too, is that patients with normal coronary arteries can have angina, ischemia, and even infarction, meaning you can have completely wide open, clean coronary arteries and still have a cardiac disease. Young people, athletes, people who look healthy, and women can have MIs. These are all true, by the way. True or false, they're all true. And an MI can occur in the absence of obstructive coronary artery disease. Believe it or not, these are all truths. So let's talk about the progression of myocardial damage. You guys have probably all heard these words: ischemia, injury, infarction, and necrosis. So the very first thing that happens is we have a reduction in blood flow. And that can be either due to a complete or a partial obstruction of those coronary blood flow. So anything like a stenosis, a plaque that is ruptured and clotted off can start causing ischemia because that blood flow is reduced. Now, if that blood flow that is reduced isn't fixed, you result in an injury, which is prolonged ischemia. If the injury doesn't get fixed or reversed, whether that's a clot that you've dissolved or a stenosis that you've stented, then you have an infarction. And again, that's an MI, that's a heart attack. It's irreversible myocardial cell death, and it's due to the lack of oxygen and nutrient delivery. So we have prolonged injury that leads to infarction. And infarction can often, depending on how bad that MI is, lead to necrosis, which is full death. So that is absolutely irreversible damage to that cardiac muscle or that myocardium. So at first, you'll have someone that complains of angina. Again, this can be classic chest pain or any pain from the face down to the abdomen, the arms, back, or shoulders. It can vary in degrees of severity and description. Patients can say anywhere from sharp, burning, stabbing, tingling, dull, achy, the wide range of pain. Can sometimes, not always, be accompanied by shortness of breath, extreme fatigue, dizziness, or syncope, loss of consciousness, changes in vital signs and hemodynamics. Again, not always, but generally. How you diagnose an acute MI? First and foremost, they'll perform an EKG or electrocardiogram and see if there are any changes, typically ST segment, but you can also have T-wave changes if you're familiar with EKGs. These are just the up and down spikes on an EKG. You're looking for changes in those. Cardiac enzymes are lab draws that you can have the patient draw from obviously their arm. It's an IV, but a venous blood draw. The most important one now is a high sensitivity troponin, but what we're really looking at is the troponin delta, which is the difference between two in a series. And depending on hospital protocol, you'll see maybe one drawn and then an hour later another. Sometimes it's 3 hours. It used to be 6 hours. That's an older troponin. But really what they're looking for is a change or a delta in two. And what we don't want to see is an increase in troponin. Chest x-ray sometimes performed just to rule out other causes of chest pain. An echocardiogram is important, but usually is delayed if all signs are pointing to a heart attack, because an acute MI, especially a serious acute MI like an ST elevation MI or a STEMI, needs to be rectified right away. In other words, they're going to the cath lab. Now, the usual cause of an MI is CAD or coronary artery disease, and it's a ruptured plaque. This is when you see, you're watching a movie and someone drops dead of a heart attack or clutches their chest and falls to the ground. It's all dramatic. That's not usually how MIs can occur, but they do. That would be a big STEMI. But what's happening is you have a plaque, perhaps it's an unstable plaque, and it ruptures for whatever reason. Now that rupture triggers a clotting cascade, and the body tries to clot it off, but in doing so, it actually obstructs blood flow. And that obstruction, that clot or thrombus, is what causes the infarction. Now again, this is the usual cause of an MI. But now we're talking about INOCA, and what is that? INOCA stands for ischemia with non-obstructive coronary arteries. In other words, we have something that looks like a heart attack that isn't caused by a ruptured plaque or atherosclerosis or stenosis or a lesion. It used to be called NOCAD, and in some countries they still do call it NOCAD, which is non-obstructive coronary artery disease. And it's very closely related to these other acronyms, INOCA and MINOCA. Again, it's a broad term, and we picked INOCA because it really is the most common use of the word. I really think ANOCA, or angina non-obstructive coronary artery disease, is the better word because it doesn't always lead to ischemia. Sometimes patients can have angina with non-obstructive coronary artery disease that doesn't progress to ischemia. And hopefully none of these progress to MINOCA or an MI with this condition. But in general, it is something that looks like a heart attack that's not caused by typical coronary artery disease. So because of that, this is something that looks like a duck, quacks like a duck, has feathers like a duck, but it's not a duck. So it's often underdiagnosed and miscontributed or misattributed to non-cardiac causes. In fact, 2% of individuals with an ischemic event, an actual ischemic event, will be misdiagnosed and discharged from the ER. Those that are more likely to be misdiagnosed are non-white, women younger than 55, those who have a main complaint of shortness of breath, normal or indeterminate EKG findings, and the tricky thing is up to 40 to 70% of patients, so about half of patients who undergo angiography or a left heart cath for angina have this condition of non-obstructive coronary artery disease, and a large proportion meet diagnostic criteria for INOCA. So what that means is they have a coronary artery disease that can cause a disruption in blood flow, but we don't know why. It's not obstructive. It's not a lesion. It's not atherosclerosis. It's not a blockage like you see typically. And this is where it gets tricky. So INOCA can lead to reduced exercise tolerance, significant decline in quality of life, frequent healthcare use. These folks go to the ER all the time because they don't know what's wrong with them and they're told there's nothing wrong with them. Significant morbidity despite normal angiograms. So in other words, this condition is not benign. You take these patients to the cath lab, you tell them they have normal coronary arteries because you can't see anything wrong with them at the time, but there's something wrong with them. We just don't see it. And it carries a high risk of major adverse cardiac events or MACE. That includes an MI, heart failure, stroke, cardiovascular death, or death. Studies such as WISE and CORMICA show that patients with INOCA have event rates similar to those with obstructive CAD, or the usual causes of MI. And again, it's almost like a ghost. You are looking for something that you can't see. You know this patient has angina, but you can't see the cause of it. And we're going to get into why we can't see these things, okay? But really what the basis of this is a disruption in blood flow that's not caused by a blockage. The interesting thing is the risk factors are very similar to CAD. The big ones, tobacco use, hypertension, diabetes, chronic kidney disease, obviously cholesterol problems. The older you get, the sicker you get, stress, chronic inflammation. The weird thing with INOCA is that most patients are female. With normal obstructive coronary artery disease, it's typically a little bit higher population in men. And then congenital heart defects that can cause the coronary artery to run an abnormal or anomalous course, meaning it doesn't come off the aorta like it should, or it doesn't course through on top of the heart like it should. Super heavy slide. I'm going to skip this one. We talked about it already. And again, we want to look at the endothelium because this is part of the reason why INOCA happens. So the endothelium is not functioning normal. Either it has kind of holes in its barrier where things can get in that shouldn't get in and things get out that shouldn't get out. And because it is a semi-permeable membrane, it's responsible for things like vasodilation, or that artery getting bigger, or vasoconstriction, that artery getting smaller. You like heavy slides, Richard. Thank you. I do too, but it is a lot. This is a very big presentation, but I have time. Don't worry. So the dysfunctional endothelium is dangerous because the blood vessels don't know when to constrict or dilate, and they don't have the ability to sense the chemicals that are telling them when to do that. And then as such, they respond differently to things like inflammation and blood clots, which is kind of scary. And in addition, endothelial dysfunction, they think, actually promotes the development of atherosclerosis, which is what causes typical CAD. So now we get into exactly what INOCA is. Again, INOCA isn't a disease itself, but it's a condition or an umbrella term for several conditions, several diseases. And the three we're going to talk mostly about are coronary artery vasospasm, coronary microvascular dysfunction, and anomalous coronary arteries, specifically myocardial bridging. Now, you guys probably have heard of Takotsubo cardiomyopathy. It's also called broken heart syndrome. There's some variation in whether or not we call it an INOCA. Technically, it doesn't obstruct coronary blood flow in an epicardial sense, but it does create some pathologies that look a lot like INOCA. So I throw it in here because I believe it fits. But the technical term are these three on top. So what do these conditions cause? Well, they cause symptoms that look a lot like a heart attack. Angina, which is chest pain. Again, it can be any kind of pain that comes from the heart, even if it doesn't sound like chest pain. Again, jaw pain, arm pain, tinglies. I've even had a patient come in that said, my left pinky is feeling weird. And lo and behold, she was having an MI, which is very interesting. This can happen with effort, which is when we typically see patients with blockages experiencing angina, but it can also happen at rest, which is almost a qualifying symptom for vasospasm. We'll talk about that in the beginning in a little bit. Dyspnea, shortness of breath, fatigue, palpitations, dysrhythmias, your heart beats too fast, you have premature ventricular contractions or PVCs, even ventricular dysrhythmias, which can be life-threatening, syncope or dizziness, and then the big, bad, ugly things: ischemia, cardiomyopathy, LV dysfunction, infarction, ventricular rupture, sudden cardiac death. I mean, these things are scary. Brian has a question that what causes the holes in the endothelium? Brian, if you can figure that out, you will be a millionaire. We don't know. So the interesting thing is we know that hypertension causes the endothelium to be dysfunctional. We know that damage to the endothelium, like with smoking is a great one. They're, putting chemicals in your bloodstream that don't normally belong there and that cause chronic inflammation can damage the endothelium, which again kind of pokes holes in that membrane. But for a lot of patients, especially these INOCA patients, we don't know. And I have an anecdote that I'll share at the end. But yeah, that's the $1 million question. We don't really know. There's risk factors, but we don't know if they're causative or just correlative. So let's talk about this first condition, coronary vasospasm. So a typical artery has a lumen, the inside of the artery where blood flows, and it's wide open. Maybe it gets narrow in times of, say, cold. For instance, if you were at risk of getting hypothermia, your distal or your peripheral vasculature is going to clamp down and not vasospasm, but it's going to vasoconstrict to shunt blood to your core. Reverse is if you're exercising or stressed, your coronary or your arteries, all your arteries, vasodilate or get bigger to allow for more blood flow. Now, the trick with vasospasm is that it will clamp shut without any need to and block or reduce that blood flow. Now, when your coronary arteries do that, they're preventing blood flow to your heart. So this isn't a let's save our fingers from hypothermia and we don't want our fingers to fall off, so we clamp down and that's why you get frostbite. But that's not what this is. It's a very sudden, severe constriction of that middle layer of the artery. So again, that tunica media, that smooth muscle layer that just temporarily blocks or occlude flow. Now, we know it's related to dysfunction of the endothelium. It can also be related to hyperactivity of the smooth muscle cells. So the endothelium is not telling the smooth muscle cells what to do correctly, or the smooth muscle cells say, you know what, we don't care what signals we're getting from the endothelium. We're hyperactive, we're freaking out, we're just going to clamp down. There can be triggers: cold weather, emotional or physical stress, again, smoking, drug use. In fact, if you work in a cath lab and have a patient, I'd say less than 30 years old, that looks like they're having a heart attack, it's probably drug use. Alcohol withdrawal. And the really interesting thing about vasospasm is that an acute sudden vasospasm typically happens in the very early morning, like 2 a.m., 3 a.m. time frame. Sometimes late at night, 10, 11 p.m. So they don't know exactly why. We think there is obviously some kind of hormonal regulation tied to that, whether it's cortisol or who knows what. But it is very interesting. If you have a patient that complains of pain at rest, they've not done anything, they've been laying in bed for hours, and they have sudden, severe, sharp shooting, stabbing, burning, whatever, chest pain, believe it or not, it could very well be vasospasm. It could also be a classic STEMI, where a plaque has ruptured, it was unstable to begin with and just decided it was time. But those typically don't, that pain and those EKG changes don't go away on their own. You have to go in and fix it. Vasospasm can dissipate on their own. Now, the diagnosis of this is super tricky because they are intermittent, unpredictable, it happens randomly, and then it disappears. Typically, vasospasm are 15, 20, 30 minutes, and then the body realizes this isn't right, we shouldn't be doing this, and that smooth muscle relaxes. Now, that doesn't happen with a classic MI. If you have a clot in your coronary arteries, it's not going to just suddenly disappear. If you have a blockage that's completely obstructing flow, it doesn't just go away. Those are interventions you need in the cath lab. But vasospasm kind of sometimes can go away on its own. Now, the tricky thing is it can cause things like ischemia and EKG changes as a result of that. But unless you capture it at the exact moment the vasospasm is happening, these tests are going to be negative. Even lab work can be negative unless the vasospasm was severe and prolonged. So the only way to catch it is to provoke it. And I think is an interesting term. What it means in diagnosis of vasospasm is you take the patient to the cath lab to do invasive coronary angiography, and you give them medicine to try to make the artery spasm, because in healthy arteries, they shouldn't. And in patients with endothelial dysfunction or a tendency to vasospasm, they will. Now, this is a tricky procedure. In fact, we used to do it, 20, 30 years ago with a drug called ergonovine. And we stopped doing it because it causes vasospasm, which is what it's supposed to do. But what does a vasospasm cause? It can cause an MI. And we were actually causing quite a few. We have someone who's asked, I have prismental angina. It was diagnosed during a cath. That's exactly what we're talking about here. So prismental is an older term. We're calling it now is what it is. It's coronary vasospasm. But you'll see, I think, several different terms for this disease. But yeah, you can occasionally see it in a regular left heart cath. But to get an absolute definitive diagnosis, it's during a provocative angiogram with a specialized test. And we'll talk about that in a little bit. Again, the tricky thing, excuse me, with vasospasm and any condition of INOCA really, is that they're very difficult to diagnose. And again, EKG changes are not observed unless you actually catch the vasospasm happening. So you're performing an EKG on the patient while they're having a vasospasm, which by the time they get to the hospital, it's probably done. It's probably stopped. You can leak troponin, which is, again, that cardiac enzyme that leaks out in the presence or during injury to the myocardium. So if the vasospasm is significant and obstructs a lot of blood flow, you can have troponin leaks, but you may not. And again, it does reduce coronary blood flow. It does reduce myocardial perfusion. Fantastic news is that it responds very well to nitroglycerin, which is very important because significant sudden vasospasm that aren't terminated can cause a myocardial infarction. And again, every sign and symptom points to that. I'll take just a moment. Any questions you guys have so far, please don't be afraid to type them in that question bar. So moving on, microvascular dysfunction. So we talked a lot about the major blood vessels of the heart, the epicardial coronary arteries, right? The RCA, the circumflex, the LAD. The microvascular are all the teeny tiny little arteries that are feeding from that. This is actually the arteries and the arterioles, or the prearterioles and arterioles, that are in the myocardium itself. So they're the ones diving down into the myocardium and actually providing blood flow to that muscle. Okay, so if you guys recall, probably from A&P, if we're talking about arteries turning into capillaries, it goes arteries, arterioles, capillaries, venules, and veins, right? So what we're doing here is we're feeding the heart with oxygen and nutrients, and we're actually giving the heart its own blood, and it returns to the venous circulation. So we're talking about these teeny tiny arterioles before we get to the capillary bed and before we start the venous return from the heart. So the muscle has used up the oxygen and nutrients in the blood, and now it's kicking out carbon dioxide and waste products. So in microvascular dysfunction, also called coronary microvascular dysfunction or CMD, it's the impaired function of these small arteries, these teeny tiny arterioles that regulate the blood flow to the actual heart muscle. And these guys fail to dilate properly, just kind of like a vasospasm, but they're kind of always freaking out. That's a functional deficit, or they can have a structural defect preventing proper dilation. The times you see this are with patients with left ventricular hypertrophy or a really thick myocardium or a stiff heart, sometimes you'll hear. And it doesn't allow the blood flow, these teeny tiny arterioles, to dilate like they should because there's an actual structural impairment. So also something super difficult to diagnose. Only some non-invasive tests can measure coronary flow, period. Usually you have to do an invasive test like a left heart cath, but we've gotten really good at seeing major epicardial coronary blood flow through stress scans, PET scans or PET myocardial perfusion imaging, magnetic resonance imaging or cardiac MRI, also called CMR. Cardiac MRIs are pretty good at showing perfusion. And then CT has gotten really advanced in the last 10 years or so in being able to see the coronary arteries. There's even a specific CT scan called a coronary artery CT angio, where you can actually get a really, really great look at the coronary arteries. And we'll talk about this in the second half of this lecture. What you see here on the screen is called a CT-FFR. FFR, fractional flow reserve, is a way to measure coronary flow. Now, the trick is it only does this on epicardial vessels, so you can't see the teeny tiny arterioles or the microvasculature. The image you see on the screen is actually showing blood flow down the RCA looks good, 0.96. This is a fraction or a ratio of blood flow in the aorta compared to the distal vessel. So normal would be 1-to-1, right? The blood flow in the aorta, the pressure and the flow is the same as it is downstream in the vessel. So you'd want somewhere around 1. 0.96 is great. 0.5, not so good. And you can see it's illuminated in red. Anything less than 0.80 is something that we should consider an intervention. Now, again, this is all well and good for coronary artery disease, obstructive coronary artery disease, but it's not going to show a vasospasm unless you happen to catch it during the test. It's not going to show microvascular dysfunction because we're not looking at the small vessels. We're looking at the epicardial vessels. So unless ischemia or injury or an infarction has occurred, even with vasospasm and again with microvascular dysfunction, these tests are going to be negative. Measuring microvascular blood flow is way more difficult than measuring the major blood vessel blood flow. So you need 2 very important tests. I want you guys to remember these: coronary flow reserve and index of microvascular resistance. So CFR and IMR are the big ones needed for microvascular dysfunction because it's going to compare and really dive down deep to show the blood flow in the smaller vessels, excluding out the flow in the epicardial vessels. Now, the problem with microvascular dysfunction is that you can't see these on angio at all, whether it's CT or invasive angiography in the cath lab, you can't see the small vessels. So you can have ischemia and be looking at the coronary arteries and have wide open, beautiful coronary arteries and not understand why this patient had a bump in troponin and has classic signs of angina. You may not see EKG changes. In fact, they're usually not observed. Sometimes in a stress test, sometimes if you elicit stress in the patient with chemicals, not so much with exercise. It can result in a chronically elevated troponin. It's usually pretty low. There's no delta unless there's a significant change in their presentation or symptoms, but they can have a chronically elevated troponin. And it does reduce coronary blood flow and increase that resistance or that pressure it has to overcome to completely perfuse the arteries. And again, it can result in chronic angina with or without acute episodes of increased symptoms. So these patients can be walking around all day long with 2, 3 out of 10 chronic chest pain. Nobody knows what's wrong with them, and nothing is fixing it. So really big bummer. Lastly, we're talking about myocardial bridging. So this is a really interesting phenomenon. It's common, believe it or not. And we'll talk about this in a minute. But we're learning that it's more common than we think. But in a certain percentage of people, it can be very detrimental and cause obstruction in blood flow. And what it is a congenital anomaly where a segment of the coronary artery is embedded in the myocardium. So it doesn't lie on the surface of the heart or that epicardial surface. It doesn't have that barrier between the muscle of fat and connective tissue and actually tunnels through the heart muscle itself. And as a result, that heart muscle on top of the artery constricts the artery with every single heartbeat. So every time you have systole, or the squeezing phase of the cardiac cycle, it reduces the inner lumen of that vessel. Now, again, most myocardial bridges or MBs are benign, but we are seeing more and more evidence that they may not be. And that in some patients, and it's interesting the patients it occurs to, it can cause severe cardiac issues. This is another thing, as with every bit of INOCA, cardiac testing doesn't show evidence of the problem. Unless there's ischemia or injury or an infarction, most tests won't be positive. Even still, there's a functional significance of the MB that must be determined. In other words, how obstructive is the blood flow? And if you think about it, when the heart beats, it's squeezing this vessel shut. And that's when the body or the heart is perfusing the rest of the body. Now, the interesting thing about coronary artery perfusion is that it occurs during diastole, or the rest phase of the heart. So the coronary arteries actually perfuse or fill with blood when the heart relaxes. So for a long time, we thought that myocardial bridges were benign because, okay, sure, it's squeezing the coronary artery during systole, but if the coronary arteries are perfusing during diastole, that's not a big deal, right? What we're finding is that systolic squeeze can sometimes, it's almost sticky. It stays squeezed even during diastole. So we had to try to find a way to figure out how to measure how much obstruction in blood flow we're getting. Now, again, we were learning that this is pretty common, but it's interesting that we only diagnose it in a left heart cath about 10 to 15% of the time. It says 0.5% to 16%. Sometimes we miss them. I think if you don't know what you're looking for, perhaps you do. CT scan, coronary CTA specifically, is a little bit better in diagnosing them. Again, you have to know what you're looking for, or almost expecting what you're looking for. So about 30 to 50% of the time we'll diagnose it. Interestingly enough, on autopsy, I don't believe 85% of the population has a myocardial bridge, but what I do believe is 50 to 75% of the population actually has a part of their coronary artery that dives into the muscle, at least a little bit, maybe a shallow bridge. But what's interesting is if we're only seeing them so prevalent in autopsies, it must mean that they don't cause problems most of the time. But in some patients, we're finding out that they do cause very severe problems. So again, that systolic compression of the artery can cause a decrease in blood flow, diastolic dysfunction as well, reduced, delayed, inadequate filling, reduced coronary blood flow, or CFR, like we just learned. And then because it is actually crimping on the vessel and producing a stress or a friction, almost like a shear wall stress friction, it can cause endothelial dysfunction just of itself. So now you have one INOCA condition, endothelial dysfunction, right, caused by another one, this myocardial bridge, which is a structural defect of the artery, because it's like taking a butter knife on a tree branch. It's not going to do a lot of damage at first, but if you keep sawing with a butter knife, eventually over time, you're going to saw off that tree branch. And that's essentially what's going on with myocardial bridging, is that it's just the muscle squeezing for 400 million heartbeats over the course of someone's life. And it just eventually it wears down that inner layer of the vessel, that tunica intima, and endothelial dysfunction occurs, which can again cause a whole host of problems. So as you can see, these diseases have a huge clinical impact. Many patients experience significant cardiac problems. There's delayed diagnosis. We don't know what's causing these problems. You don't have a blockage in a major vessel. It doesn't look like you're having a heart attack, but sometimes they are. So these things, if not diagnosed quickly, can lead to things like heart failure, arrhythmias, MI, or even death. And awareness is key in preventing misdiagnosis and unnecessary procedures. Now, we talked a lot about complications with diagnosis. EKGs, echocardiograms, which is an ultrasound of the heart, even lab work can be completely normal. So unless you're catching these events while they're occurring, or they're severe enough to cause an injury or ischemia or infarction, you may not be able to do a test, perform a test that shows any kind of abnormality. Kevin Piku asked the question, so are we saying that continuous compression every systolic phase also can cause spasm in the diastolic phase? Does bridging lead to more general spasm? Really good question. The bridging isn't what causes the spasm. The bridging causes the dysfunction in the endothelium, and then that causes spasm. So The bridging is there from birth. It's a congenital defect. So that artery was tunneling through the myocardium from the beginning. What we know is that shear stress or that friction on the vessel over time can damage that endothelium to a point where it can no longer compensate for that damage, and the endothelial dysfunction can then cause spasm. The interesting thing about spasm is that, again, it doesn't happen all the time. It does have this weird habit of happening early in the morning or late at night, and it's at rest. So it's very weird or very interesting that it occurs. It doesn't often occur with exercise or with exertion. And why we think that is because when you exert yourself, you actually produce more nitric oxide. So perhaps there's an element, again, I say perhaps because we don't know a lot about these conditions. Perhaps there's an element of having an increase in nitric oxide from being active during the day, from exercising, walking around, doing your job. And then as you rest at night, your body produces less nitric oxide, and then you have a spasm. They are related. Not everyone who has a myocardial bridge will have endothelial dysfunction. Not everyone with endothelial dysfunction will have vasospasm, believe it or not. And not everyone with vasospasm can even determine where it came from. But we do know that these are all connected, and that sometimes they do lead to each other. Going back to the slides, again, this generally says, in general, no test can really capture these pathologies. Conventional tests might miss them. There's no gold standard. There's no definitive way of determining whether you have well, there is. We'll get to that in a minute. But there's no general test. There's no basic test that you could walk into any ER in the country right now, and they're going to do X, Y, Z. Now, for heart attacks or CAD, there's a protocol. You walk in, you say you're having chest pain, you're going to get aspirin most of the time. Some hospitals don't do this anymore. You're definitely going to get an EKG. You're definitely going to get lab draws, troponins. If your troponins are positive, even slightly positive, they're going to admit you and try to find out why. If they're very high, they're probably going to send you to a cath lab. And if you have significant EKG changes, you're probably going to go there fast. So there's a protocol that looks the same across the country and here in the US. The tricky thing about INOCA is there are no guidelines. There's no societal guidelines. There's no general physician group that says, here's what you do. We're establishing that, but it's not established yet. So in general, you're going to miss these conditions. So for MBs, myocardial bridging, sometimes you'll see them on angiography, sometimes you won't. Sometimes you see it on CT, but you kind of have to know what you're looking for. With vasospasm, you're not going to see it at all unless it's actively occurring. So you have to provoke it. And then microvascular circulation, you can't see it all on any imaging. You have to measure the coronary blood flow or the resistance that blood flow has. So in other words, you need provocative testing. Provocative testing is a newish term. I didn't know about it when I was in the cath lab, but I learned about it quickly in looking at this condition. And really, it's invasive angiography, so a left heart cath, but we're doing more than just looking. We're measuring, okay? So yes, we're imaging. We're going to use some other imaging, interesting imaging techniques, intravascular imaging, so inside of the vessel. We'll take pictures from inside of the artery, which is really cool. Or we're going to do some kind of special procedure, giving a medication and equipment to measure. And again, these things aren't done in every cardiac cath lab. In fact, there's very few in the country right now that are doing it. Briefly, I do want to talk about excuse me, the treatment options for each of these conditions, because they are very different. In general, for vasospasm, calcium channel blockers and long-acting nitrates. So things like amlodipine, diltiazem, long-acting nitrates would be like a nitro patch or Imdor, and then trying to change whatever caused the endothelial dysfunction, if that's really contributing to the vasospasm. So getting the patient to quit smoking, maybe exercise a little bit more, get control of their diabetes or hypertension, things like that. We don't generally stent vasospasm. There's actually a few physicians that are doing that for very focal or short segments of spasm. But in general, we're not stenting them. And that is because the stent it has a higher risk of restenosis, because the spasm can actually damage that stent and allow it to restenose faster. So the rate of restenosis in general for any coronary artery stent is, I think we're down to like 1 or 2%, even less. But in stenting a vasospasm, the risk of restenosis is 25%. So it's generally a higher risk. And there's nothing we can do surgically or with an implantable device that can fix vasospasm. Now, for coronary microvascular dysfunction, the medication's a little different. We use beta blockers as a first line. The reason we don't use beta blockers in spasm is actually beta blockers have been shown to actually make spasm worse. So they generally don't prescribe beta blockers for patients with spasm. But then calcium channel blockers, ranolazine, which is Ranexa, is a great medication. It's actually off-label use in CMD, but it works really well. We've just learned that ACE inhibitors and ARBs can sometimes help a lot with CMD, which is interesting. And then the same lifestyle modifications. Get your patient to stop smoking, control their blood pressure, yada, yada. Again, stenting we can't do because these vessels are so super, super tiny. We don't even put a wire down that vessel, never mind a balloon or a stent. So stenting's off the table. And currently in the US, there's no surgical treatment. There are 2 devices. They're both coronary sinus occluders or reducers. So this is a stent that sits in the coronary sinus, which is the large, it's a vein technically, the venous return of the heart. So the blood that has perfused the myocardium and provided the heart with all the delicious oxygen and nutrients as it's leaving the heart to get returned to circulation, right? To go to the lungs and dump off its CO2 and get more oxygen. There's a large vein and it exits the heart. And there's a device, we're currently studying it, that slows the flow out of the heart. The thought behind that is to increase the flow before it. So it's almost like you're creating a dam. And in creating a dam, you're allowing that river to be really, really deep. In other words, we're giving more of the heart muscle more oxygen and blood. It's an interesting concept, and it's one that's still kind of theoretical. They don't really know how this device works because it does increase the pressure the heart has to overcome to perfuse. But for whatever reason, and it's really interesting, the IMR, or the index of microcirculatory resistance, doesn't increase. So we are increasing the resistance, but we're not increasing the resistance. So if you look at this device, it's funny because we don't know how it works. But the one that's out there now that we're testing is a device by a company called Shockwave. It's called the Coronary Sinus Reducer. And then they're about to start the trial, a company called VahatiCore, on their version of this stent. Treatments for bridging are tricky. Again, beta blockers, the reason we like beta blockers in some of these conditions is that it reduces the myocardial oxygen demand, it reduces the workload of the heart, it lets the heart rest a little bit more, and therefore it can relax and open up. So the thought process behind beta blockers with myocardial bridging is that it reduces the constriction on that muscle bridge over the artery, so that systolic compression is a little less. Calcium channel blockers as well, lifestyle modifications. Stenting is usually not recommended. Again, similar reason for vasospasm, but this one much more severe. If you stent a myocardial bridge, you will very likely fracture that stent and have an increased risk of in-stent restenosis. So we definitely don't stent MBs. Now, I say definitely, and there are a few that do, that have okay outcomes. We don't know why. Some do well and most of them do poorly, but we don't generally stent these. And then surgical unroofing, which is I don't want to say it's a newer procedure, but it is newly done in some hospitals. Stanford in California has actually been studying unroofing, which is a myotomy or a muscle removing of that muscle bridge over the coronary artery. Stanford's been studying it for about 15 or 20 years, and they've been collecting data just anecdotally in a registry. But what we're finding out is that surgical unroofing, or taking that muscle bridge off of the heart, actually works for a lot of patients who have failed medical management. So they've taken beta blockers or calcium channel blockers, they've quit smoking, they're exercising, they're doing everything they should be doing, and they're still having chest pain, angina, ischemia, infarction from this bridge. So nothing's working. Now there's a lot of barriers actually to appropriate care. I think the biggest one is really that many healthcare providers have never even heard of INOCA. They may have heard of something called small vessel disease, which is what cardiologists called patients who had angina, but normal coronary arteries. They said, oh, it's just dysfunction of their small vessels. which could be true, especially in CMD, but we didn't know much about it, so we just called it small vessel disease. And now we are aware that it's actually quite a significant event that can cause these problems. Misconceptions and dismissal of symptoms. It's really interesting, especially with women, perimenopausal women who come in with complaints of angina. We check their troponin. Maybe there's a bump in troponin. We do a stress test. Maybe it's positive or maybe it's not. Maybe it's borderline. We take them to the cath lab. They have clear coronary arteries. And we say, you know what, lady, you're perimenopausal, or it's stress, or it's anxiety, or gosh, you have 4 kids and you work 2 jobs. It's not your heart. You're fine. Go home. And then they have chest pain at home and they come back and we do all the tests again and they're all negative. And we tell them, lady, seriously, stop coming to the ER. You're fine. And it turns out it can be these INOCA conditions. It can be coronary vasospasm. And if we haven't tested for it, we may not catch it, right? Because to see these things on imaging or on things like EKGs, they have to be happening at the same time. We have to catch it. So inadequate testing and misdiagnosis is a big barrier to care. There's a lack of options. Right now, other than these investigational devices or open heart surgery, it's just meds. And sometimes these meds don't work. The really interesting thing with INOCA and medication management is that it's trial and error. Some calcium channel blockers work better than others in some people, and in other people, they don't. It's really hit or miss, and you have to really experiment with trial and error to see the right combination of medications. There's definitely a bias towards medical management over surgical treatment of myocardial bridging. Unfortunately, there's no surgical treatment for any of the other conditions. We don't have any guidelines. There's not a lot of research on this. There's only maybe a dozen to 20 physicians in the country right now really trying to understand this condition. There's a network of them. They all communicate to each other and they're really trying to understand it. But the rest of the country hasn't adopted it. They really don't understand, and very few cardiac cath labs are even testing for these conditions. So you see that disparity in care based on where you live. If you happen to live near Yale, the folks at Yale are studying this. The folks at Stanford are studying this. Cleveland Clinic, Christ Hospital in Cincinnati, hospital in Tampa. Some of the hospitals have physicians that are studying it, but even in these hospitals that are recognizing it, some of the other cardiologists don't. So there's this big discrepancy and disparity in care. I think I finished about right on time, but I would love to take any questions that you guys have if you haven't asked it in the question box. I would love to answer any questions. We went through that really fast. In the next session of the presentation, we are going to get into a little bit deeper in how you diagnose that, because that's really the imaging portion of this is the really fun part. But if you guys don't have any questions, I appreciate you guys sticking around for this introduction to INOCA. And our next session, we'll get into it.
Actually, Jennifer, we do have some questions in the questions box there. Are you able to open up the questions box?
I can see if I can see more.
Okay, let me go ahead and relay those questions to you.
Yes, please. That'd be great.
Okay, so this one comes from Brian. What causes the holes in the endothelium?
Yeah, we chatted about that. I think I answered that question earlier, but I'll go over it again. So the endothelial dysfunction, or having that endothelium be permeable when it should be semi-permeable, we don't really know. We know that some things can contribute to more of a prevalence of it. So things like smoking and hypertension, dyslipidemia, what we've learned about lipoprotein A, in fact, is a big one. But we don't know why it happens because it doesn't happen in all patients. So not every patient with hypertension has endothelial dysfunction. Not every patient with dyslipidemia has endothelial dysfunction. So we know it is correlative, but we don't really know if it's causative. That's really interesting. The next question I saw was about prismatic angina, which is another name for coronary vasospasm. And then I think I answered Kevin's question about myocardial bridging with that systolic compression. Myocardial bridging is probably the most trickiest INOCA condition to understand. And we'll certainly in the next presentation learn why it's the most difficult one to diagnose and really determine its functional significance. In other words, how badly is it obstructing blood flow? It's the trickiest condition to test for, and it's the one we probably know the least about.
Okay, Jen, we still do have about let's say 15 minutes more for this segment here. If you can go back through your slides and
Yeah.
probably you can probably give us some more information on a couple
Sure.
of
I
the
was
yeah.
flying through it because I wanted to make sure. Um, I do want to talk more about these conditions, so I can absolutely do that.
Okay, thank you so much.
Yes. So going back to our pathologies. So again, coronary artery vasospasm is the intermittent constriction of the coronary arteries. Now, here's the tricky part. I didn't get into this, but now that we have time, I can do that. You can actually have these conditions occurring at the same time. So in other words, you can have vasospasm involved in microvascular dysfunction because the dysfunction of that small vessel or the small arterioles can be vasospasm. So while you may not have epicardial vasospasm, you can measure and diagnose CMD or coronary microvascular dysfunction, and you can determine a type. It's called an endotype. It's 4 distinct types of CMD. One of them is a functional endotype, and we know that it's functional. There's no structural damage. There's no structural impairment to the arterioles, but we know that they don't have good coronary blood flow, and we can measure coronary flow reserve, which is a comparison of coronary flow at rest versus stress. And so in measuring that, we can determine, along with the index of microcirculatory resistance, which is IMR, whether one is positive and the other is positive, or they're both negative, or one's positive, one's negative. We can determine an endotype. So coronary microvascular dysfunction can have 4 endotypes. And again, one of them is you have a low coronary flow reserve, but normal IMR. So there's no structural deficit to those small arterioles, but they're not flowing well. And that's when you contribute that microvascular dysfunction to vasospasm. So again, these things can kind of all happen at the same time and contribute to each other. That structural deficit that we talked about is when you have a very slower than normal coronary flow and a high resistance. So there's something clamping down. It could be disease. It could be atherosclerosis only in the microvasculature, which is causing a disruption in blood flow and increasing the resistance to that blood flow. And that's at a structural endotype. So it's very interesting that you can have these things happening all at once. Now with myocardial bridging, again, we talked a little bit about, let's skip through that. Myocardial bridging, we talked, is kind of the most difficult INOCA condition to really diagnose. And the reason for that is, for a long time, anyone working in a cath lab will tell you they've seen many of them. They're not rare. They're not common. You don't see them every day or every week even. But once in a while, you'll see a patient with myocardial bridging. And we'll talk in the next lecture on how we can determine what that looks like. But you'll see these occasionally. And for a long time, and still in many, many places in the country, we don't think much of them. We say, oh, okay, it's just a bridge. You don't have a blockage in your artery. Isn't that great news? You don't need a stent. Stenting, of course, you have to take dual antiplatelet therapy that increase your risk of bleeding, and you have a piece of metal in your heart artery that doesn't want to be there. So stenting, while helpful, isn't something a patient would want. So we tell them, oh, great news, it's just a bridge. What do we do for bridging? We throw beta blockers at you. We reduce the workload of the heart, but what we're really trying to do is reduce that compression to that vessel. And you can see here in this image, this is actually a really great image. We see that deep bridge tunneling through that heart muscle. That pink is the heart muscle. So every time the heart beats, every single time it squeezes, it compresses that coronary artery. And in doing so, you reduce the lumen diameter, or that path that blood flows. So you reduce the amount of blood that can flow past it. So the thought process of giving a patient beta blockers is that squeeze, that muscle strength, it actually is less. It weakens, it not necessarily weakens the heart muscle, but it reduces how much it's squeezing. So for a long time, we would see myocardial bridges and say, no big deal, here's some beta blockers, you'll be fine. That's all well and good, but the interesting thing about bridges, I say interesting thing, it's all interesting to me. Patients who like to exercise or get their heart rate up, that's where we see more of a danger with myocardial bridging. We don't know whether it's because people who exercise more often, their heart beats more, right? If you have a 40-year-old who's never run a mile in their life, and then you have a 40-year-old who runs marathons every weekend, their heart physically beats more often, and they've had more heartbeats over their lifetime. So they've had more opportunity for that artery to be stressed by that bridge, by that muscle. So it's interesting. We're looking at athletes with myocardial bridges a little differently. People who present with myocardial bridging problems, the younger they are, the more active they are. We're seeing that patients with myocardial bridges who aren't as active present later in life with problems. Patients who are active present a little bit earlier. So we're trying to figure out, is it just a heartbeat problem? Is it your heart has beat a certain number of times, and that's when the endothelial damage happens? We don't really know. Again, the weird thing is that on autopsy, most people actually have some myocardial bridging. They have a segment of their coronary arteries that goes in the muscle. And in fact, if you think about it, we all have arterioles that go into the myocardium, right? That's where they belong. The arterioles go into the myocardium to feed it oxygen. So it's interesting that when the major epicardial vessel, or that big vessel feeding the heart, it can't function as well diving through the myocardium. But these small arteries and arterioles that are feeding the myocardium don't have a problem with the constriction that muscle has. There's varying information and really thoughts on that. Some of it is because the smooth muscle changes from a major epicardial or major coronary vessel to the smaller vessels. The endothelium may or may not be different. We don't really know because we can't get in there and look. It's smaller. We look at it under histology slides and it looks the same, but we wonder, is it functioning the same? So myocardial bridging is definitely the one that we understand the least and is far more difficult to diagnose. I do want to talk a little bit about, again, the treatments, because I kind of brushed through these really quickly, and I do want to kind of go back. So again, vasospasm, we mentioned earlier that beta blockers actually can cause problems. There's one caveat to that. There is a drug called nebivolol, which is a beta blocker. It is the only one recommended for coronary vasospasm. Every other beta blocker, which beta blockers are medications that end in LOL typically, metoprolol, bisoprolol, there's several others. Metoprolol is probably the biggest one that you'll see provided for patients. Again, reduces myocardial demand, reduces the constriction of the heart and the workload of the heart. But beta blockers can precipitate vasospasm. We don't really know why. Nebivolol is the one exception. So calcium channel blockers are usually a first-line treatment. And what that does, it actually prevents the vasospasm from happening to begin with. So there's two classes of these medications. Either one works good. In fact, there are some physicians that say one class of calcium channel blockers combined with the other class of calcium channel blockers is the right way to go. But again, for a lot of patients, it's trial and error. And you try the patients on one, see how they do. If they don't do well, you might try them on another. Maybe you add a long-acting nitrate like Imdor isosorbide. There's two types of isosorbide. Isosorbide mononitrate, which is a longer-acting version, isosorbide dinitrate, which is a short-acting version. And we'll talk about nitrates too, because I think this is important. It is actually, I think, it's part of the first-line treatment. Calcium channel blockers are really number one, but number two is long-acting nitrates. And honestly, in my anecdotal opinion, I think it's a great drug to treat vasospasm. We know in angiography or an invasive heart cath, and we'll see images later on, we know that nitrates completely resolve vasospasm 99.9% of the time. Sometimes it takes a lot of nitrates or nitroglycerin. This is a medication we give intracoronary. So in the coronary artery, we inject it directly into it. And again, 99 times out of 100, it will relieve the vasospasm completely. So nitrates work really well. I don't know why they're not first line. Probably because they're seen as treating the vasospasm versus preventing it. But from what I've seen with patients that have this condition, providing them long-acting nitrates as part of their medical regimen does actually prevent the vasospasm. So the caveat to nitrates or long-acting nitrates, I'm not talking about sublingual nitro. That's an acute short-acting medication that every cardiac patient should have, with few exceptions, because that will dilate the blood vessel. That's really the goal of nitrates. It completely dilates the blood vessel. So even patients with coronary artery disease, typical obstructive CAD, should have sublingual nitro that they carry around with them at all times. Because if they have any kind of acute chest pain as a result of a blockage, the nitroglycerin will widen and dilate that artery to give them more blood flow past it. So sublingual nitro, there's also spray nitro. They use a spray more often in Europe, but usually in the US, you'll see sublingual. It's a small white tablet you place under the patient's tongue, and within 5 minutes, really, they have a relief of their chest pain. Again, there's a caveat. The caveat to long-acting nitrates are the ones that stay in your system longer. They take a little bit longer to work. You can only take them with a nitrate-free interval, which means if you have a long-acting nitrate that works for maybe 10 or 12 hours, okay, it has a longer half-life than a short-acting nitrate. In other words, you need a nitrate-free interval in your body, or you will become tolerant to the medication, right? So this is something that if you take 24/7, eventually your body says, you know what, forget it. I don't even care that you're here. You're not going to do what we need you to do. You're done. You become tolerant to it. So then you need more. So then you increase your dose of nitrates and you're taking them 24/7, and then your body stops responding to it. So then you need more and more and more. So what we've learned with nitrates is that you need a period where your body doesn't have any nitrates in it. So typically you'll take this medication that works for 10 or 12 hours, and you only take it once a day. And then you have a 10 or 12 or 14-hour period where you don't have nitrates in your system, and then you don't have that risk of building a tolerance to it. Now, interesting, there's no tolerance building with sublingual nitro. So if you have a patient who they're having angina, it's persistent, you can't figure it out, you're trying to adjust their meds, and they take sublingual nitro like candy, they actually don't have as much of a risk as the tolerance as to these long-acting nitrates. And again, the long-acting ones are the nitro patch, which is just a subdermal patch you put on your body, or these medications like Imdor. So yeah, that's a really important factor for the treatment of vasospasm using nitrates, is that you really, really have to impress upon patients that they have to have a period where they're nitrate free. And for a lot of patients, they don't love that because they have kind of their chest pain that creeps on, and you can have an underlying vasospasm. So it's almost like if you guys have heard the COPD patients who have acute on chronic COPD, right? So they have this chronic condition, but then they have an acute exacerbation. Vasospasm, we're finding out, can actually have the same thing. So you can have someone who kind of has vasospasm at baseline. It may not be a complete obstruction of their blood flow, but at baseline, their coronary arteries are trying to vasoconstrict. And then they have an acute episode where it completely shuts down, and they have that kind of acute on chronic thing. So you have patients that have this that feel better with nitrates. Their chest pain goes away. They can climb the stairs without getting short of breath. They feel better. So they want to take these meds all the time. And we have to impress upon them that it's really bad for them if they do, because they're going to need an increasing dose of these nitrates. And all of these medications they're not without side effects. The big side effects of all of these meds is that you lower your blood pressure and sometimes your heart rate. Now, for normal cardiac patients, that's usually not a big deal because most of those patients have hypertension. But what we know in INOCA is that these patients don't look like normal cardiac patients. They're not the old obese guy smoking a cigarette, eating McDonald's. They don't look like that. That exercise we did in the beginning, these patients don't look like they should be sick, and yet they are. So it's really tricky to treat them, and giving medications that lowers heart rate and blood pressure sometimes can be detrimental to these patients that don't have hypertension. I like that Brian asked, so exercise is actually bad for you. Yeah, something I've thought about, believe it or not, even lately, is how much is too much. I think everything in moderation. But if our heart's beating with a myocardial bridge in place, maybe we have a limited number of heartbeats, and we should just be careful not to use all of them at once. I don't know. It's an interesting thought for sure. What we do know is that moderate exercise does help all of these conditions. The trick to them is that we teach patients to pace themselves, meaning they don't want to exert so much effort that they're wiped out the following day. What we do know is that a moderate level of activity improves coronary flow. It vasodilates these vessels. Even when you have endothelial dysfunction, it increases the oxygen going to the heart, improves nitric oxide. We make more nitric oxide. We respond to it better. So a little bit of exercise is good, but what we're learning in some of these patients that there's a point where they tip the scale, and too much is actually quite bad for them because they can't compensate for it, and then it just kills them the next day. They're just so fatigued. That's a fun question, though.
Actually, it is. All right, Jen, I think we can end off this segment here.
Awesome.
All right, well, thank you, everybody. Let's go ahead and take a 10-minute break. We come back at 7:20. Let's take a 10-minute break, get some refreshments, and when we come back, Jen will rejoin us for our second lecture. Time check, everybody. 1 minute. All right, welcome back, everybody. Welcome to Amado, Andrea, Angie, to Anne, Brian, Annie, that's Brian G and Brian K, Selena, Conrado, David, David N and David V, Fernando, Guillermo, Jose, Joshua, Juan, Kevin, Lisa, Marsha, Michelle, Marshall, also to Philip, Raul, Rebecca, Richard R, Richard W, Roger, Steve C, and Steve V. Welcome back, everybody. Hope you had some really nice refreshments. And at this time, we'll take you back to Jen for our second lecture. All right, Jen, it is back to you.
Excellent. Thank you. I'm really glad that I got through everything I wanted to get through in that last one. I don't have to talk as fast this time. So
absolutely,
that's really good for me because, shoo, I was out of breath. All right, so objectives. So we've talked a little bit about INOCA and really about 3 unique forms of it. The second part of the lecture is really focusing on imaging and the imaging modalities that we can use to help diagnose these. Because as we learned, these are really difficult pathologies to diagnose with standard cardiac testing. So the role of imaging is very important. There's invasive angiography that we can do, testing we can do within a left heart cath. We'll talk about IVUS and OCT, which are intravascular modalities. We'll chat a little bit about the difference between a routine left heart cath and a provocative angiogram or a provocative invasive heart cath, and comparing functional and anatomical imaging modalities, both non-invasive and invasive, and really determining the best one for each of these conditions. Coronary function testing is something that I definitely want to touch on, and we'll talk about that. Coronary function testing is important for these conditions, but it's not something that's offered in every cath lab, so certainly not in every hospital. However, it's very important for the diagnosis of all of these conditions, in fact. So we'll look at the kind of the unique differences between coronary vasospasm, microvascular dysfunction, and myocardial bridging, and how they all appear differently on all of these imaging modalities. We'll talk about the advantages, the limitations, and the clinical applications of them, as well as how the outcomes influence treatment strategies and long-term management. And then most importantly, at least for me, promote the awareness of INOCA as a distinct, under-recognized condition, especially in women's cardiovascular health, but really in cardiovascular health in general. So diagnosis of INOCA, we have, these are certainly not all of the imaging modalities you could use to understand cardiac disease. These are the ones that you'll see most often. So invasive coronary angiography is what we usually see when we say a left heart cath. Interestingly enough, here's a little bit about background of that word. Left heart cath technically needs a catheter to enter the left ventricle. So technically, you could do coronary angiography and not actually perform a left ventricular catheterization. So it's a little bit of a misnomer, believe it or not. Invasive coronary angiography, angiography is the correct term for looking at the coronary arteries with a radiopaque dye under fluoroscopy. This is basically, though, a left heart cath. Coronary CT angiogram, it's a little different than a CT, a regular CT scan, and we'll talk about why that is in a little bit. Coronary CT angiography is a really great tool to get a general idea of coronary artery disease, really obstructive disease, but it can also show some myocardial bridging if you know what you're looking for. Cardiac MRI is another great tool. It's one I'm actually less familiar with. We don't generally do cardiac MRIs as routinely because they're a little bit more expensive. Same thing with myocardial perfusion imaging, as far as if you do the best one, which is a stress PET scan. That's actually a decently expensive procedure as well, although it gives great information. And we'll talk about that in a little bit. Echocardiogram is one that is performed all the time. It is non-invasive. It is very easy to perform. It is an ultrasound of the heart. The easiest one is a transthoracic. You take an ultrasound probe, the same probe you look at when you're looking at, a baby's health, the health of a fetus. It's just done on the heart. So it's external. There's nothing internal or invasive, and is just an ultrasound using sound waves to look at the heart. Really great tool to see the function of the heart, the structure of the ventricles and the atria, the chambers of the heart, as well as the valves. The two we're really going to focus on, though, are invasive coronary angiography and coronary CTA. So first, basic left heart cath. This is performed in a heart cath with usually conscious sedation. It is the gold standard in diagnosis of obstructive coronary artery disease, so the typical CAD that we see in patients: atherosclerotic lesions, stenoses, plaque ruptures, and a radiopaque dye is injected into the coronary arteries during fluoroscopy to directly visualize the lumen of the vessels. And that's really important. If you don't know much about left heart caths or coronary angio, we don't actually see the structure, or we can't visualize the arteries themselves. What we're looking at is only the lumen. So this radiopaque dye is injected, and we can see it as it flows through the lumen, or the inside tube of those vessels. It does allow for immediate percutaneous coronary intervention, or PCI. So while you're doing the diagnostic angiogram, if you see a blockage that needs to be stented, you can do it right away because you're already there. And usually these patients who undergo these procedures are consented for intervention, even if we don't think they need it, because they're going to be under sedation in the procedure room. So we'd rather have that consent than not, because we can perform the intervention at the same time as the diagnostic angiogram. Now with INOCA, all of these INOCA conditions, there are no obstructions. That's part of the name of the condition: ischemia with non-obstructive coronary arteries. So PCI is unnecessary, and in fact, you probably shouldn't perform it. But in patients with ischemia that have a clean heart cath or a normal heart cath, additional tests should be performed to determine what is causing their ischemia. Whether it's vasospasm, CMD, or MBs, the problem is that these tests are not widely available. Myocardial bridging can sometimes be observed, which is different. Vasospasm, you likely won't see it unless a vasospasm occurs during the cath. Now, you can have catheter-associated vasospasm, in which you take the catheter to inject the coronary artery, and as you engage it into the ostium, or the opening of that vessel, the vessel freaks out. It doesn't like something that shouldn't be there being there, right? So it can sometimes clamp down. What's really interesting is that we've seen this, and we just call it catheter-associated vasospasm, but now we're wondering if healthy endothelium doesn't do that, because some patients, you can engage a catheter and you can actually set it very deeply into the coronary artery, and the vessel's fine. The coronary artery doesn't freak out, it doesn't vasospasm, it's doing just fine. Other patients, you tickle the ostium with the catheter and it vasospasms shut. So now we're wondering, is it really catheter-associated vasospasm? Or does vasospasm just, when it's present, it does that? Very interesting. CMD you will never see on imaging. You will never see it on a left heart cath because these vessels are so small. You can't even really see them fill with dye. You can see the dye blush, is the term, where the myocardium, you'll actually see the outline of the heart as this radiopaque dye moves through the small vessels, but you can't see each individual vessel. It's almost like a watercolor painting. You don't see any brush strokes. You just see the general color. Again, myocardial bridging can sometimes be observed, not always. And what we know is that we actually can only observe it with its classic sign about 5, maybe 10% of the time. And we'll see that in a second. Brian asked the question, I have seen with MRI that there is an exam sequences for coronary arteries. Have you ever seen these done? These are done, but CMR is, for whatever reason, not the most utilized imaging. And again, it does go back to they're a little bit more expensive, but it's very underutilized. And cardiac MRI can be very, very helpful in these conditions for sure. Because it's not well utilized, I know less about it, and that's why, honestly, the only reason I'm not talking about it here. So this is a left heart cath. You can see the catheter coming up from the bottom of your screen from 6 o'clock to 12 o'clock. That's the catheter. It kind of turns around, and you can see the tip of the catheter right now. As I play it again, you'll see it inject the radiopaque dye. This is the left system of the heart. So this is the left main artery. It bifurcates. Actually, in this case, it trifurcates. There's 3 branches or 3 forks in the road. And in that case, when you have that, not common, but we have the circumflex, we have the LAD, the left anterior descending, and when you have a trifurcation, you have what's called a ramus. Again, not everyone has a ramus, but that's that middle artery between the LAD and the circumflex. Now, this is just one view. This is a single view of the heart. So because the heart is a 3-dimensional object and we're looking at it in 2 dimensions, you'd have to get multiple views, multiple angles to really understand what's going on. In this case, we're only looking at really the left main is really outlined very well. You can see the trifurcation of those 3 epicardial vessels. But we're not getting a great image of all of them because they're kind of overlapping onto each other. But that's the left side. This next video is the right coronary artery. So the right coronary artery comes off the right cusp of the aorta. And in any view, it looks like a C or an L. This is actually a pretty large RCA. And if you look super closely, I'm going to see if I can pause it. You can actually see that there is some vasospasm at the ostium, or the start of that vessel. This shows it really well. So vessels should always get more narrow the further distal, the further down you go. And in this case, you can see that the catheter is engaged in the ostium, and that ostium is actually a little bit more narrow than further down that vessel, if you guys can appreciate that. And that is a catheter-associated vasospasm. Now, again, I don't know that that term should even exist because I think vasospasm is vasospasm. Whether the catheter induced it or not, this vessel spasmed. Healthy vessels shouldn't. I really think this is really just my opinion. You'll have physicians that say, oh, a wire can cause a spasm, tickle the artery, it can cause a spasm. I think I'm gonna put money on it. I think we'll learn the next 10 or 20 years that healthy arteries shouldn't spasm at all. And that vessels that spasm as a result of a catheter or a wire or a stent or a device are unhealthy. I'd put money on it. That's just my opinion. But in any case, you can see the ostium, or the beginning of this RCA, is definitely spasming. Now, the good news is that it's not contributing to any major flow problem, right? You can see the rest of the vessel. In fact, it's a beautiful RCA with a PDA coming off of it, a PLB, RV branch, an acute marginal. I mean, all these branches look great. So it's definitely getting a lot of blood flow. But if that vasospasm at the ostium were to completely occlude that vessel, this would be a problem. So great image of an RCA. This is an actual left heart cath because we have a pigtail catheter that has engaged and entered the left ventricle, and we're going to inject a dye through it now into the left ventricle so you can actually see the pumping chamber of the heart, the biggest pumping chamber of the heart, in fact. The left ventricle is injecting blood out through the aortic valve into the aorta so that the rest of the body, including the coronary arteries, can perfuse. And you can actually see kind of the highlight of those coronary arteries perfusing kind of at the end of the injection. You can kind of see them filling with blood as that dye is exiting the left ventricle. The reason we do a left ventricular angiogram, or an LV gram as they like to call them, is to see and measure the left ventricular function. And a lot of folks will just eyeball it. They'll say that's normal function. A normal ejection fraction is around 60%, depending on who you ask. 55 to 65 is normal. Some go as low as 50, some go as high as 70. Bottom line, about 60% is normal. And this heart is pumping pretty decently. Those with really good eyes might notice a little bit of an anterior defect. It's not perfect, but it's really good enough to say it's fine. That is a left ventricular angiogram. Now, this is a the view of the left. So this is the left main. We know that the left main normally bifurcates into the LAD and the circumflex. And this is not a normal image. And I want to see if any of you can really determine what's abnormal about it. Again, this is a still shot. It's not a cine. It's not a video run. So it's tricky. But I want to see if any of you can even type in the questions, if you can see or describe what might not be normal about this. And I'll keep talking as I'm waiting for you guys to answer. But this one is, if you're looking at the biggest vessel coming from the top left side of your screen going down to about the 5 o'clock position, that is the LAD. That's a left anterior descending artery. I know it's the LAD because I have septal perforator branches that they always look like they're raining down. If you think about when you have a storm and the rain hits your windshield or your window, and the rain just kind of drips down, septal perforators definitely do that. They look like they're raining down. Other branches of the LAD include diagonals, and we have a really, really great diagonal coming off here. Circumflex is not shown in this image so much, it's the very top of the screen, but what we're really trying to do is lay out the LAD. And a few of you are getting it right. There is the top of the image looks stenosed, yes. So if you look at the very top, again, vessels, coronary arteries should narrow as they go further down, right? But if you have a sudden narrowing, and you can appreciate that, I think. I'm actually going to see if I can draw it, because I like doing that. There is a giant chunk missing from that artery. That is a very significant stenosis. That does not warrant any further interrogation or investigation, because that is so significant enough, you know it's obstructing flow, perhaps more with exertion than at rest. But I can even tell that this vessel is not getting enough flow. Like we've got things that don't look normal, areas that look kind of weird, and it's probably because it's not getting enough flow. So that big old pinch in the LAD, as Kevin says, is something that we definitely have to investigate, or stent. We won't even investigate it. We're going to balloon and stent that sucker. So that's abnormal. Now, in some cases, you could have stenosis that maybe doesn't look as severe, and you want to investigate it further. So there are actually technologies you can use. You put them inside of the vessel, and you can image from inside of the artery. Isn't that crazy? This almost looks like a video game I used to play. I'm going to tell how old I am. I used to have a Sega Genesis, and I can't remember the name of the game, but it was, you were driving a spaceship through tunnels, and man, this looks a lot like it. You can see from inside of the artery. Now, there's two different types. Again, IVUS and OCT. IVUS is intravascular ultrasound. So we're using sound waves to bounce off, almost like echo sonar, like a dolphin would, to send out a sound wave. It bounces off of objects. Sometimes it moves through objects. Sometimes it bounces everything back. And a catheter picks up that bounce back, that reflection, and produces a cross-sectional image. So super cool, because you can actually see part of the vessel. Intima is really hard to see. Again, the endothelium is a single layer of cells. So it's kind of hard to see a single layer of cells, but you can definitely see the media because it is beefy, it is smooth muscle, it's thick. And then that adventitia, there's definitely a separation between the adventitia and that media you can see. OCT is optical coherence tomography. It actually uses light to do the very same thing, but because it uses light, it gives off a little bit better image. And I say a little bit, it's actually a lot better image. You can see the clear delineation of the lumen of the vessel and the vessel wall, which is very, very helpful. You can also see stents reflected back. Now you can see stents on IVUS as well. OCT is less utilized, and I'm not really sure why we haven't adopted it as much as we have IVUS. IVUS did come first, which typically results in a higher and increased use of utilization. But OCT is a great tool as well. Again, both of these can provide imaging from inside of the vessel. So why that's helpful for some INOCA conditions, we'll talk about it later, is that you can see what's going on. Now, going back to coronary vasospasm, we talked about catheter-associated vasospasm. This is actually a really good image of the catheter, which you see in blue, and red is the coronary artery. This was a spasm of a left main. Now, the tricky thing is vasospasm is intermittent and unpredictable. Clean cath doesn't rule out the existence of it. This one we happened to see it because it was catheter-associated. The vasospasm was induced by the catheter engagement. It doesn't rule out the condition. It doesn't rule in the condition, although I think it should. But because you can't always see vasospasm, like you might have a patient that has a predisposition for spasm, but the catheter doesn't show that. It doesn't induce a spasm. In other words, we must provoke the vasospasm. We must make it happen. We're gonna pick at it, and we're gonna make it happen. How we do that in coronary arteries is through a medication called acetylcholine. So acetylcholine is a neurotransmitter that, for normal patients, provides a little bit of vasodilation, like 5%. You hardly even notice it. It generally doesn't do much to healthy endothelium. But in dysfunctional endothelium, acetylcholine provokes vasospasm, pretty significant at times. So what we do during this part of coronary function testing, which I mentioned in the beginning of this procedure, coronary function testing is testing the function of the coronary arteries. The acetylcholine provocation is seeing if a vessel has a tendency to vasospasm. Is it going to do it? Usually with acetylcholine, it'll vasospasm with endothelial dysfunction, not always with smooth muscle hyperreactivity. So you can have two different causes of vasospasm again, the dysfunctional endothelium and a hyperreactive smooth muscle, or that middle part of the vessel. We're seeing more endothelial dysfunction, a sole hyperactive smooth muscle. You'll have other problems going on with your body if your smooth muscle is not functioning right. So really it's endothelial dysfunction. Now the trick to this provocation is that we're causing the vessel to clamp down on itself. We're causing vasospasm, which we know disrupts blood flow. And what do we have when we disrupt blood flow? We have ischemia. Prolonged ischemia can cause injury. Prolonged injury can cause infarction. Infarction can cause necrosis. These are all bad things, right? So if we're provoking these bad things, we're making these bad things happen, we have to be ready to reverse it. And again, intracoronary nitroglycerin is what does that 99.9% of the time. So you have to have it ready to go, ready to inject directly into the coronary artery to relieve that spasm. Again, because severe vasospasm can cause big problems. Now, there's a limitation to this test. So to undergo coronary function testing, your patient has to be off all cardiac medications for 1 to 2 days. And the reason for that is you want to see what their coronary arteries do by default. And if the patient's been on medications like calcium channel blockers or long-acting nitrates, we're trying to prevent vasospasm. And in this test, we don't want to necessarily do that. So the patients have to be off their meds. Now, the trick to that is some patients, when they go off their meds, have vasospasm, which means they could have a heart attack. So it's kind of a delicate balance. And in fact, there are some patients that can't come off their medications because they will have such a severe vasospasm that they will have an MI every time. So it's tricky because you don't want to blunt the response, but you don't want the patient to have a heart attack either. The risks are the same as a left heart cath, but they are increased because we're invoking something and provoking something that could cause a complete disruption in blood flow. So here is just an image of a left heart cath. This is, again, the view of the left main. The LAD you can see come kind of from the top of the screen straight down. The circumflex in this view looks like a C with a little squiggle at the end of it. The very top vessels it's actually a ramus. This is the same patient that we showed earlier with that trifurcation of the left main. So there's a large ramus at the top that's kind of overlaying on top of some diagonal branches. So this is normal. This is actually after the provocation with acetylcholine, after they've given nitro and the vessel looks normal. And you can see here's our circumflex. Don't mind that little zip. Here's the LAD. The ramus is up here. Left main is nice and juicy, wide open. This is great. Those vessels look fantastic. Now, the next image I'm going to show you is after the patient was given acetylcholine. Can you guys see the difference? First of all, the big thing I noticed is that that ramus is gone. It's not there anymore. We've caused such a vasospasm, such a significant vasospasm, that that ramus is totally occluded. I'm also looking at this circumflex. We would call that subtotally occluded because I can at least see it. I know where it's supposed to be because there's a little thread going through it. But holy moly, it is pretty small. It's subtotally occluded. I'm also looking at this LAD. It looks okay till about here. And then it's narrow. It gets a little bit bigger here. It's narrow. We would call this diffuse spasm. And then if you're really got a good eye, you notice that the left main is significantly vasospasm, so much so that I'm clamping down on that catheter. So the second picture, the picture on the right, is actually the first image in the series of coronary reactivity testing or coronary function testing, in which we gave that neurotransmitter called acetylcholine to provoke the vasospasm. Now, this is a severe vasospasm. Usually what you'll see, let me take off all of my little marks so that you can really appreciate it. Usually what you'll see is a focal vasospasm, meaning you have something that looks almost like the stenosis we looked at earlier. But this response was so significant that it caused multi-vessel vasospasm. This is actually quite insane. Now, what you'll notice, if you have a good eye, is that there's some things going on here. Do you guys know what these little dark circle things are here? Does anyone know? You can type it in the questions if you'd like. Don't all answer all at once. Fantastic. Sternal wires, yes. Cabbage, Brian, interesting. So yeah, right away you'd think, okay, this patient had a cabbage, but funny enough, I tricked you. This patient did not have a cabbage. This patient had open heart surgery, but what they had done was a myocardial bridge unroofing. So this patient went to surgery to take off a myocardial bridge that used to be right here. So the patient went to surgery, had the myocardial bridge removed, so myotomy of that bridge, that muscle bridge over the artery no longer exists, and then went back to the cath lab because they were continuing to have problems, and they did an acetylcholine provocation and determined, hey, guess what? The bridge wasn't the only issue you have. You have vasospasm too. So those sternal clips or those sternal wires were not from a coronary artery bypass graft. There was no graft. We didn't take a left internal mammary artery and put it anywhere, or saphenous vein grafts. The only thing we did, the only reason we had a sternotomy here is to take that myocardial bridge off of the LAD. So tricky question. I tried to trick you, and I got you, Brian. So now we're talking about angiography, left heart cath with coronary microvascular dysfunction. We've already talked about the fact that you can't see these teeny tiny arterioles on any imaging at all. You can kind of see them blush. You can kind of see this watercolor image of the dye moving through the heart if you're looking at the microvasculature. But the best way to do it, gold standard, is PET scan, positron emission tomography, and again, cardiac magnetic resonance imaging, or cardiac MRI. Again, we don't do cardiac MRI as much as we should, I think. PET scans or PET perfusion, stress PETs are pretty expensive as well, but we do those a little bit more. They actually give you a little bit more information. And the information you can get from a PET scan, specifically a myocardial perfusion stress PET, is that coronary flow reserve. Now, you can't get IMR on a PET scan. The only way you can get IMR is to do this coronary function test in a left heart cath. And the reason you need that is because you have to put a wire down those vessels and measure pressure and blood flow. You can do that a couple different ways. There's a Doppler ultrasound to do it, and then there's thermodilution. We won't go into that, I don't think, too much here. We'll see if we have time. But what we're doing is comparing a baseline flow, which is resting, versus a stress flow. So we want to measure the blood flow and the pressure when the heart's kind of chilling out. and we're going to take one aortic pressure, and we're going to compare the distal blood pressure down the distal part of that artery. And then we're going to give a medication. Typically, it's a medication called adenosine to stress the heart. So if you've taken ACLS, you've probably heard of this medication. In larger doses, it is used for an antiarrhythmic, but in smaller doses, it just opens up the distal microvasculature. It opens the floodgates wide open. So there's pretty much essentially no microvascular resistance in healthy vessels. So we're opening the floodgates, and it's inducing something called maximal hyperemia, which is blood flow, the maximum amount of blood flow, and we're going to get pressure measurements off of that. Now, coronary microvascular dysfunction can be, again, we've talked about this functional or endothelial endotype, or a structural or non-endothelial endotype. That's getting really into the weeds on what CMD is, so we won't talk too much about that. What I do want to show you is what this testing looks like. So the arrows are pointing to the wire that we've put down. It's usually the LAD, because the LAD is, again, the mamma jamma artery. It's the big important one that's feeding the left ventricle, which is the pumping chamber of the heart. The LAD, the widowmaker, the super important. They're all important. They're all, especially the epicardial vessels. But the LAD, if you had to argue, was your favorite child, this is your favorite child. So these arrows are pointing to the wire down the LAD. And what we're doing is we're measuring pressure from aorta compared to the distal part. We talked about this earlier when we talked about CT-FFR. So ideally, the ratio of your blood pressure in your aorta is equal to the blood pressure way downstream in your coronary arteries. So if you put it as a ratio of each other, it should be 1, right? If the blood pressure is 90/60 in your aorta and the pressure in your vessels 90/60 way distally, the ratio of that is 1. Anything less than 1 is not perfect. Now, there's a point where not perfect becomes so abnormal that it can trigger ischemia, as seen on stress tests. And we've done studies to show that number, that ratio, or that cutoff is 0.80. When we take an FFR, again, that pressure ratio, using a medication called adenosine, that FFR of less than 0.8 is functionally significant, meaning you've obstructed enough flow under stress that it can cause ischemia. And we've studied it to know that. And what you're looking at here is pointing at the difference in flow. Now, IMR is different. And you can see at the bottom right of your screen, they haven't quite measured the IFR yet in this image. But we're looking at the FFR in yellow is 0.93. So that's not normal, but it's not abnormal. It is good enough. It's not 1, but 0.93 is fine. We haven't quite measured a CFR, which is coronary flow reserve, which is another type of pressure measurement, right? We're looking at the coronary flow, and we have to use pressure to get flow because it's tricky to measure flow. And again, we haven't quite measured our IFR or IMR there. What does that all mean? Well, if you're a science nerd, or you're someone like Brian who likes the super heavy slides, or Richard, I think you said, I like the super heavy slides. This is a super heavy slide. So CFR is that ratio of hyperemic flow divided by resting flow. Hyperemic is we're giving the heart all the juice it can get. We're opening the floodgates. The microvasculature is dilated as well as they can get. It's full on. The gates are wide open. And then we're comparing it to a resting flow. Normal coronary flow reserve, the reserve is what we're measuring, is greater than 2.5. So hopefully you all have CFRs of 3s and 4s and 5s and maybe even 6. Borderline or a gray zone is 2.0 to 2.5. So we're able to measure that with this wire. And there's a couple different wires that we're using in the US. Right now, the one that's being used most is Abbott's CoroFlow wire. And that's one that measures the flow by seeing how long it takes a saline bolus to move through the vessel. And we measure that flow by measuring the temperature, because we know that the slower it goes, the more it's going to warm up to body temperature. So it's called thermodilution. Now, IMR is different. We're measuring the resistance of the downstream teeny tiny vessels in the microvasculature. IMR is equal to the distal coronary pressure multiplied by mean transit time. So that's, again, how long that blood took to get from where we injected it to the distal part of that vessel where we're measuring it. We want IMR to be low. You should have a low resistance. In other words, your blood should be flowing pretty freely at this point with the adenosine going down your microvasculature into your capillary bed of the myocardium. So we want the resistance to be low. In fact, it should be less than 25. If it's greater than 25, we know that you have coronary microvascular dysfunction. And depending on whether your CFR is abnormal or not, depends on the endotype. Moving on to myocardial bridging. Again, we talked earlier, sometimes you can see this on angiogram. But we have to find a way to measure and quantify the things that it does. And we know the things that it does is systolic compression. So the systolic narrowing caused by the compression of that artery on top of the vessel that is somewhat relieved during diastole is called a milking effect. And we're going to see a picture of it in a second. Now, the trouble with that is that you can't always see this milking effect. In fact, it's usually only demonstrated in about 5 to 10% of patients with myocardial bridging. So it's very insensitive. In fact, most bridges are not visible on angiography at all. We know that. Something that's cool, it's not great, but it's cool. Nitroglycerin actually can unmask myocardial bridges. There's this paradoxical systolic overshoot effect. Now, what does that mean? When you give nitroglycerin down a coronary artery, it dilates the coronary artery, right? Now, what it can't dilate is heart muscle. It has no effect on heart muscle at all. So while it dilates the healthy part of the vessel that doesn't have a myocardial bridge on it, we're not dilating the myocardial bridge. So in essence, we're giving that blood, that coronary artery, so much blood flow, it's getting more blood flow, but it still has the same amount of compression because that muscle doesn't change with nitroglycerin administration. Distal to that myocardial bridge, the vessel's trying to wide open again. So as a result, you actually see this milking effect that I'll show you in a second. So that nitroglycerin can actually unmask it. Now, the trick is that it can actually cause more pain because the heart wants more blood flow, but that myocardial bridge is restricting it just as much, even though that blood flow is trying to come. So again, it's almost like a dam stopping up and the river really wants to flow and it can't. And so here kind of is what that milking effect is. This first image on the left is just a still image, a still shot. And what I want to impress upon you is that if you were only looking at a still image of a myocardial bridge, what does it look a lot like? I'm going to outline for you here. This is the segment of coronary artery that has a bridge over it. You can see that it's restricting flow. This is during systole. In fact, this is during the high point of systolic compression. This is the most this vessel is constricted. I snapped a picture of it. But what does it look like? You guys know? If you were to only look at a still shot of myocardial bridging, you might think it's stenosis. You might think it's an atherosclerotic lesion. But what I want to show you, if I can play the image, here we go. Looking at that same spot, this is the LAD we're looking at. Again, that circumflex in this view kind of forms a C. And what we're looking at, if I can point to it, right around here, is we see that that vessel vasoconstricts and then releases. It's constricting, and it's actually not a vasospasm because it's the muscle that is doing it. It's the heart muscle, not the smooth muscle of the actual artery. It's the heart muscle that is clamping down on that vessel during systole, during the squeezing part of the cardiac cycle. And it's restricting blood flow momentarily during systole. And then it's releasing it during diastole, or the resting part of the cardiac cycle. Oh, I meant to erase and I'm highlighting. So I want to make sure you guys can see that because this is a classic milking sign that you don't always see. I'll go back to it because I want to see if we can see it again. This is actually a classic example of milking that you don't always see with myocardial bridging. So the reason this one showed up is because they injected nitroglycerin and it produced this systolic overshoot. So there was so much blood trying to get past that myocardial bridge there. And you can even see the vessel almost, it almost kinks, right? I think you guys can see that. So again, you don't always see this on coronary angiography or in a left heart cath, even when bridges exist. You won't see this systolic milking effect in every myocardial bridge, but when you see it, it is a myocardial bridge. A better way to determine if it's how bad a bridge is to perform intravascular imaging, so IVUS or OCT. On IVUS, you can see myocardial bridge. It looks like an echolucent half moon. We're going to show a picture of it in a second. You can see it kind of throughout the cardiac cycle, but you can definitely see that it's localized only to the bridge segment. So it's not present throughout the entire artery, but you see this half moon shape where the myocardial bridge is. OCT is a little trickier. It doesn't show MBs as well. And we're going to show kind of exactly what we're looking at here. So if you can look on, F is the greatest example, I think. Bottom left-hand corner, even D shows this pretty well. That IVUS image looks like an eyeball staring at you, if you guys can see it. There is a muscle band, which is a darker image that almost forms like your eyelid. If you're looking at the lumen of the vessel as the eye and the pupil, there's this, and I'm going to actually point it to you guys so you guys can see it. See how it almost looks like an eye? That's why, this one especially, that's why IVUS is really great at showing myocardial bridging. OCT, I don't really think it's as good. Apparently it's here, I don't see it. This is a side branch, by the way. But what this looks like on histology, if you were to cross-section the muscle and the artery, you can see that right here is a layer of muscle on top of the artery. That shouldn't be there. This is all connective tissue and fat that should surround the artery normally. But in this patient, the myocardial bridge, now it's not a complete bridge, okay? It's not going to the other side, but there's so much muscle tissue, and you can see it in H. This is all muscle tissue. And this is the adventitia, the outer layer of that vessel. There's a little bit of subcutaneous fat here and connective tissue, but we're looking at kind of the vessel down here. This shouldn't be there. So that muscle bridge, and that we can see it here on IVUS. And again, even on invasive angio, this milking effect, this isn't a great one. I mean, there's a little bit of what looks like constriction here, but really you see it really well on IVUS. Now, unfortunately, most interventional cardiologists, when they see a myocardial bridge, they don't IVUS, again, because we've underappreciated how bad these things can be, how functionally significant they can be, that, again, we're just like, oh, great, no stent needed. You just have a bridge. We'll give you some beta blockers. You'll be fine. So a lot of times we don't do invasive imaging on them, and maybe we should. Now, the best way to measure how bad a myocardial bridge is to do a functional assessment of it. And what we're going to do is we're going to, again, measure blood flow from the aorta and compare it to blood flow past the stenosis or past the lesion. Now, I'm going to talk about this. This is generally when we do this with normal coronary artery disease, so obstructive coronary artery disease. So outside of myocardial bridging, we can do that FFR again, that aortic pressure compared to distal to the lesion pressure. We want that number to be 1, okay? We can do different types of measurements of pressure, whether we're doing it with adenosine or a hyperemic agent like adenosine, or a newish, it's probably, I say newish, it's probably about 10, 15 years old. A new way to measure the pressure in a vessel is to do what's called an IFR. This is an instantaneous wave-free ratio. It's the same measurement, but we're doing at a specific point in the cardiac cycle to where we don't need adenosine or a hyperemic agent. Sometimes they use dobutamine, which is another kind of agent that doesn't really just dilate the distal microvasculature, but it's going to increase the heart rate as a way of stressing the heart. So adenosine doesn't increase the heart rate so much. It does a little bit, but the reason it's a stressor is because it's opening the floodgates, that distal microvasculature. It's just opening those gates wide open. Dobutamine, on the other hand, doesn't do that so much. It just increases the heart rate, so it's like the heart's stressed out like exercise. But IFR is an interesting pressure measurement because it's looking at a specific point in the cardiac cycle where there's no heart movement at all. So it's during diastole, there's no electrical activity, there's no squeezing. It is the absolute resting phase of the heart. And it's taking the pressure at that exact moment. Another type of pressure measurement is resting full cycle ratio. It's just another type of ratio that doesn't need adenosine or dobutamine. It's a little bit trickier to measure, so we don't do it as much. Now here's the trick. All of these, and I'll actually go back, all of these guys right here work wonderfully in obstructive coronary artery disease, in static lesions that are there no matter what part of the heart cycle we're looking at. Myocardial bridges are not static. They are dynamic lesions. And what I mean by that is they compress more during systole, which means they have a smaller lumen during systole. And then during diastole, it's different. It's like a different vessel, right? You look at it and you're like, it almost looks wide open. And then another squeeze happens, another systolic squeeze, and the lumen gets smaller. And then diastole happens and it gets bigger. So it's smaller, bigger, smaller, bigger. So because it's different and it's dynamic, these tests don't work, which stinks. FFR and distal or distal FFR normally use adenosine to create that hyperemic state. And what we know is adenosine doesn't really show the problems with myocardial bridging, because myocardial bridging, again, it's a squeeze during systole. And if we have a long period of diastole, we have more time for the coronary arteries to perfuse. So how we have to measure the significance in coronary perfusion with a myocardial bridge is increase the heart rate. And because adenosine doesn't do that, we're not seeing the worst of the worst. We have to get the heart rate up to decrease the time the heart spends in diastole, or the resting phase of the heart. In other words, if you're sitting here right now listening to this lecture, bored out of your mind, your heart rate's 60 beats per minute, you have a lot of diastole happening. However, if you're like me and you're sweating because your boss happens to be on this presentation watching you right now, your heart rate's 120, you have a smaller period of diastole. So in other words, my coronary arteries have less time to fill than yours. So we know that with a higher heart rate, you have less time for coronary artery perfusion because your heart is spending less time in diastole. And the only medication that does that is dobutamine. Adenosine doesn't do it enough. Oh, I do actually want to go back. Now, the trick with dobutamine is that it's not used often. We use adenosine all the time for FFR. But another caveat to this is that FFR doesn't even work. And IFR is what we know to show that how much that myocardial bridge opens up or releases on diastole. And the reason IFR works better is because IFR, again, is that instantaneous wave-free ratio. It's taking the pressure measurement from the aorta compared to the distal part of the vessel past the MB, excuse me, and it's going to take that pressure measurement when the heart is completely relaxed, when there's no electrical activity, when there's no movement. It is a nanosecond. It is a moment, a super small moment in time that it captures this pressure measurement. And typically, because it's doing that at this exact moment in time, when everything is calm and the distal resistance is as low as it can possibly be, we don't usually use a hyperemic medication. So with IFR, you don't need adenosine or dobutamine. But what we just learned is that for MB measurements and assessment, we have to have the heart rate up. So we have to give dobutamine. So what this means is we're doing IFR with dobutamine, which is not standard of care. In fact, it's never been studied, and it's totally experimental and off-label. But it happens to be what we think is the best way of measuring the true significance of a myocardial bridge, because it's mimicking a stressed state. It's basically dobutamine. I've heard one physician call it exercise in a bottle. It is mimicking exercise as best it can. But this is not something most people do. If you asked a cath lab to measure IFR with dobutamine, they'd look at you like you're crazy, because IFR doesn't use medication. That's a benefit of IFR, is that it's taking that pressure measurement at a moment in time where you don't need a hyperemic medication. So asking a physician or a cath lab staff to perform this test, it's wild. It's not something they normally do. In fact, we don't have a lot of evidence because there's not many MBs out there. We haven't tested them. The ones we have tested, we do show that that is the best way to functionally measure them. So I actually want to go back. Those of you who plan to work in a cath lab or are working in a cath lab, I would love for you to take a picture of this and just note kind of where we got this information from, the citations at the bottom, because there is evidence that the best way to measure the functional significance of a myocardial bridge is to perform IFR with dobutamine. There it is. I've said it. Coronary CTA. When you're looking at myocardial bridging, again, the benefit of a coronary CTA is that it's non-invasive. You hit a CAT scan, you get an IV because they have to give you some medication, you get contrast dye, it highlights the blood vessels, it's super cool. It's pretty non-invasive. It's really good at detecting calcium. If you guys have heard of a coronary artery calcium score, this is how they're getting it. Calcium shows up bright on imaging because it is dense, it reflects back light, it reflects back sound, it does not allow dye to move through it, so you can really get a good outline of any calcified lesions in a coronary artery, even just in a CTA. However, it's not as great as assessing myocardial bridging, unless you know what you're looking for. So again, a coronary CTA, great tool to kind of pre-screen patients that look like they might have coronary artery disease, but they haven't had an MI, they haven't had positive troponins, or maybe even a positive stress test, but they're showing all signs and symptoms that maybe they have disease. So we're going to do a coronary CTA. The trick to coronary CTA is that to get the best blood flow down a coronary artery, you have to vasodilate that artery with nitroglycerin and then control the heart rate so that you have more diastolic coronary filling time. We just talked about the fact that exercise or a higher heart rate reduces the amount of coronary flow you get in your coronaries because there's less time in diastole, which is when coronary flow happens. So you have to keep the heart rate low. So you're giving a beta blocker. Keep that in mind. So coronary CTA in INOCA, again, super great advantage. You get a great image. It's non-invasive. You can see a normal course of an artery. You can sometimes see, again, myocardial bridging if you know what you're looking for. We have this newish advance in CTA called CT-FFR. We just talked about FFR. Here are the limitations in looking at a CT angiogram in INOCA. You have to pre-medicate. We just talked about having to give beta blockers and nitrates to improve the quality of imaging. That's going to affect the result. We just mentioned that we need the heart rate high to show the functional significance of the myocardial bridge. And we talked about the fact that nitrates are really great at relieving spasm. So if that myocardial bridging is causing endothelial dysfunction, is causing vasospasm, we're giving the medications to prevent that from happening, right? So really it's tricky to be able to get the imaging you need with INOCA conditions because the medications and the things you need to do to get the imaging, it reduces the outcome of the test. So the relation of symptom severity to the depth of MB is unclear. What that means is that even some superficial myocardial bridges can cause significant blood flow restriction. And we've even seen some deeper bridges not cause as much blood flow restriction. So it has no real relationship to death. Now, at a point, I say to a point, if you have a very, very deep myocardial bridge underneath a lot of muscle tissue, of course, it's going to cause more problems. But it's interesting that it's not always relative to the depth of the bridge. So here's what it looks like. And I do have a question I want to get to. Selena asked, it can take time because the heart rate has to be below a certain rate. Yes. So to be able to perfuse during a coronary CTA, you have to get the heart rate. Ideally, they like it under 60, believe it or not. So they're giving metoprolol or other beta blockers to really slow the heart rate down quite a bit to fill that coronary artery. And you can see here, this is one view of a coronary CTA. There's tons of images you can get from a coronary CT. This is just one. And what you can see is that the normal coronary artery is separated from the myocardium, or that heart muscle, by a layer of epicardial connective tissue and fat. And what these arrows are pointing to is the area of myocardial bridging where there is no protective layer of connective tissue and fat. And you can see that the coronary artery, and let me get my little drawing out. Here's your coronary artery. This is the LAD. traveling down. This is a segment or section of connective tissue and fat, this darker section, right? The lighter gray that I'll outline here is the myocardium. So you can see where the arrows are pointing to. The vessel is actually kind of touching the myocardium. It shouldn't do that. It should always have this protective layer, kind of like icing on a cake, this protective layer of epicardial connective tissue and fat. And in this case, right here, it does not. And I'll show it over here on this other side as well. And on that right image, you can actually appreciate the constriction of that vessel. There's compression there because we've got a nice juicy vessel here. It narrows down distally as it should. But what we see here is that it's almost pinched. It's more narrow here than it is further distal, which is not normal. In this case, yes, the MB appears to lie right on it. Now, here is even a better image because we can see where the myocardium, where the bridge actually is. Here it is. And I've highlighted over here. You can see that the heart muscle actually is overlaying that coronary artery right in here. And that's what's providing that systolic compression. And if I were to kind of outline my artery, this is all normal. That looks great. This is pretty good. But again, my artery is touching the myocardium here, and as a result, it gets pretty narrow right in there. I actually didn't do the greatest job with my drawing there, so I'm going to erase these so you guys can see, again, just how much compression the lumen of that vessel has. And again, this is a coronary CTA that shows this myocardial bridge. Does better than left heart angio or invasive coronary angiography, but it's still not the best because we miss these things all the time. So let's go back to what we learned in the first presentation regarding treatment. Coronary microvascular disease, the only thing we can do right now is meds. There is an investigational device out there. So the coronary flow occluder or reducer devices, there's 2 companies that are trialing that in the US right now. It's basically a stent. It is an hourglass-shaped stent that disrupts flow leaving the heart to allow the blood flow to stay in the heart longer. But right now, again, it's investigational. It's not commercialized. You can't go out and request this. You have to meet study criteria to be allowed in the trial. So not everybody can get this in the US. So that leaves only medications for people suffering from coronary microvascular dysfunction, which stinks. For vasospasm, same thing. There's no devices, there's no surgery. The only thing we have is meds. Again, there's some physicians out there who will stent a focal spasm, but in the images of spasm we saw earlier, no, we can't stent that. You'd have what's called a full metal jacket. You'd have stents everywhere. We're not going to do that. Myocardial bridging has a little bit more options. Not only do we give medications, but again, we can have open heart surgery in what's called myocardial bridge unroofing. And that is where we remove the muscle tissue that is overlaying the myocardium. Here's a picture of it. It's a little wild, I'll warn you. In this image, what they're doing is they have this, what looks like thread underneath the LAD. I think this is the LAD. It looks like it. And they're making sure that vessel is completely free of myocardium. So it's basically like flossing underneath it to make sure there's no muscle tissue attaching to it. They've already performed myotomy. They've already removed the muscle tissue, and that coronary artery is now wide open. There's no muscle tissue over it. So again, open heart surgery. This one's a sternotomy. So they've cracked the sternum, which is the bone on the front of your chest, and spread it apart with these dividers here, the metal spacer, to open up the heart and be able to get a good visualization of it. It's not the only way to do this, but this is just this instance. So again, unroofing involves surgically removing the muscle fiber that forms the bridge, allowing that artery to have free flow. Again, it's not the only way. So sternotomy is one way. That's the way most physicians would perform most open heart procedures. Now, there's something called a minimally invasive thoracotomy, where they make an incision, I think it's between the fourth or fifth rib, I might be wrong, it might be fifth and sixth. They make a pretty large incision there and go through the muscle of your chest to reach the heart. Now, the trick to this one is it hurts a whole lot more. Your sternum doesn't have as many nerve endings as your muscle tissue does. So it's a little less invasive, but recovery can actually be a little bit more painful because we're spreading your ribs apart and going through muscle. A newer one out there is robotic assisted endoscopic myocardial bridge unroofing. This is where you have 4, 5, or 6 teeny tiny puncture sites where they use a scope, just like the Da Vinci robot. In fact, it is the Da Vinci robot, to be able to perform myocardial bridge unroofing without the need for a major incision or a sternotomy. This is very rare. In fact, there's only about 6 places in the United States that do this now. The biggest physician doing this is a physician in, I believe it's Houston, Texas. Stanford also does it. Cleveland Clinic also does it. There's a physician in Atlanta, and that's about it, really. There's a few others that are using this, but you have to be specially trained on this robot to be able to do this. And then there's other risks associated. It sounds like the easiest option, and for patient recovery, it 100% is. But the tricky part is that you can't get a really great visualization of the entire heart like you can with a sternotomy. If you open a chest, you crack a chest open, you can almost observe most of the heart. You can't quite see the posterior wall, the back wall of the heart, but you can absolutely see the entire anterior, the apical or the distal part of the heart, the base of the heart where it attaches to the aorta. You can kind of move it around and see a little bit of the lateral sides of the heart. So sternotomy gives you a better view, but obviously comes with additional risks. So I do want to show kind of the benefit of surgical unroofing. And we mentioned earlier, we had the patient with vasospasm with the sternal clips. And I asked, why are the sternal clips there? And some of you said cabbage. And I said, no, it's actually unroofing. The patient didn't have a cabbage. There's no coronary artery bypass graft at all. But what we did was we opened the chest to remove that muscle tissue. So what we're looking at here is the image on the left is pre-unroofing. This is the most systolic phase, the greatest squeeze of that muscle we can get. That arrow's pointing to where the myocardial bridge is. And on the right side is a heart cath post-unroofing at the highest point of systole, the biggest squeeze, and the arrow's pointing to where the bridge used to be. Now you can still see it's not perfect, right? Let me get my little pin out again. So here we can see, I mean, that's almost like, I don't know, 98% occluded. That's pretty tight. And while this is not 100% normal, right? It's better. It is much improved. It's not perfect. It's not normal, but we can definitely tell that there's an improvement in blood flow at the same phase in the cardiac cycle, the same amount of squeeze. That blood flow is much better in the post-unroofing versus the pre-unroofing. Now, we do have a lot of studies that show that surgical unroofing can lead to significant and sustained improvement in anginal symptoms and quality of life, especially exertional angina. The reason that is, we talked about this extensively, the higher the heart rate, the decreased amount of coronary blood flow. So with exercise, you would have much more blood flow after unroofing than you would pre. So patients who have an active life would benefit significantly because they don't have as much exertional angina. And in fact, this patient doesn't have exertional angina at all. We know that these results are durable. Postoperative imaging confirms that bridges don't grow back, right? You can't regenerate heart muscle. So the normalization of coronary flow is sustainable. Now, what you can have is scar tissue. So there are some patients who have scar tissue involved that can restrict blood flow. So why is further research and education on this important? Well, I want to share just a few patient stories. These are all patients that I have been involved with in their, even from diagnosis through treatment. So this is from Tim. He says, after failing a stress test, I had a clear left heart cath, a clear right heart cath, a clear cardiac MRI. I was told I had a false positive stress test. But the Cleveland Clinic said you didn't have a false positive stress test. You had a false negative heart cath. You had a false negative right heart cath. You had a false negative cardiac MRI because they did a provocative angiogram. they performed coronary reactivity testing, and they found a myocardial bridge and severe coronary vasospasms. So this proves, again, it's just an anecdote, it's one patient's story, but it does show that they can have completely normal tests other than a failed stress test, which even his first physician ruled out as false positive, and still have significant problems with these INOCA conditions. Here's another one. When I told the nurse practitioner that I got dizzy walking around the block, she told me to wear compression socks and drink more water. Now, why would she tell you that? Well, because that's a decent response for someone with hypotension or POTS, which is postural orthostatic tachycardia syndrome, which is another coronary disease that is underdiagnosed and underrecognized, but we know a little bit more about. So yeah, a good recommendation for those conditions, but for INOCA, not good enough. Wearing compression socks and drinking more water is not going to resolve coronary microvascular dysfunction or vasospasm or myocardial bridging at all. Here's another one. This one's from Tony. This is actually, she has a great story. She actually had a myocardial infarction with non-obstructive coronary arteries. In fact, she called 911, and the very first EKG that the paramedics took showed a STEMI, an ST elevation MI in the LAD. So the EKG essentially confirmed 100% blockage in her widowmaker. She went to the Mayo ER. They took her to the cath lab, and she had pretty much essentially clean coronary arteries, meaning she probably had a vasospasm that was so restrictive on her LAD that it convinced the EKG she was having a heart attack. In fact, she did have a heart attack. It was a heart attack. It was an obstruction because of vasospasm. But what it wasn't was a completely occluded LAD because of atherosclerosis. So when they got in there to stent her, there was nothing to stent because there's no plaque there. It was all vasospasm. They did discover that there was a myocardial bridge, but even after a heart attack, they told her it was benign. So she was sent home. They said, don't worry, it's just a bridge. They gave her medicine. The medicine didn't work. In fact, they probably gave her beta blockers, which now we know causes vasospasms. In fact, she had dozens of vasospasms, so much so that she was looking for any way of getting help. She self-advocated, found a surgeon to perform the unroofing of that myocardial bridge. And believe it or not, she's one of the lucky ones. As soon as she had her myocardial bridge unroofed, she was completely asymptomatic. In fact, she says the last vasospasm she had was the night before her surgery. Now, that's not typical. That's an exception. And that's a pretty significant story. She remains asymptomatic today, even though she had a significant myocardial bridge causing really, really bad vasospasms. And normally when you have a myocardial bridge causing that much vasospasm, you've had endothelial dysfunction, and you may continue to have vasospasms even after unroofing, which is unfortunate. And all of the images we've showed tonight was from a patient who had that exact experience where patient had exertional angina. This is the case study we looked at all tonight. Exertional angina. Did it make sense for this patient? The patient's looks healthy, doesn't have hypertension, doesn't have dyslipidemia. Why is this patient having exertional angina? They go to the ER and, oh my goodness, it's a positive troponin. That's strange. Let's work this up. We do an echo. The echo looks okay. We're transferring the patient to a hospital where they can get cardiac cath done. Before we do the cardiac cath, because it's a weekend and it's not emergent, it's not a STEMI, there's no EKG changes, right? We're going to work this patient up. We have time to do that. We'll get this patient done on Monday. This is a Saturday. So they do a PET scan. And the PET scan showed abnormal coronary flow, or abnormal coronary flow reserve, CFR. Again, we can measure that with the CT scan, or the PET scan. Sorry. So PET scan was abnormal. Okay, that's weird. This patient shouldn't be having abnormal results, but actually they do. So we do the heart cath, we find out the patient has a myocardial bridge. Okay, well, we'll give you meds. Complicated, this patient can't take beta blockers because their resting blood pressure is 90/60. So we can't give beta blockers. All right, well, we'll try calcium channel blockers. Give the patient calcium channel blockers because their only symptom at this point is exertional angina because of a myocardial bridge. right? Okay, we give you calcium channel blockers. Patient's still complaining of odd pain, and then 3 weeks later has a heart attack, an actual heart attack. Patient has sudden, severe, acute chest pain, 10 out of 10, volcano erupting in the chest, urgently goes to the hospital. Now, we've just done a heart cath. We did the heart cath to find the myocardial bridge. The coronaries were clean. What could be possibly causing an MI? So we're not going to do another heart cath because we know they're clean, but we draw troponins. The troponins are blazingly positive. So now we're thinking, oh my gosh, this was probably vasospasm, and it was probably the result of the myocardial bridge. We need to remove that sucker. So the patient had the myocardial bridge unroofed, and we're thinking, great, maybe the vasospasms will stop. And the pictures we show earlier, and I can go back if we need to. In fact, I think I will. Let's go back. This is all the same patient, by the way. All of these images, the reason I have them is because this is all the same patient. So let's go back and show, yep, this is the patient's left heart cath, the very first left heart cath, right? We see that myocardial bridge. 3 weeks after this image, the patient had a heart attack. So now they're realizing that myocardial bridge is dangerous. We didn't do any invasive testing on it, but a heart attack happened. So we want to unroof it. And we have images, the CT scan that I will get to eventually. Here's a CT scan of it that we did after the heart cath. So we know that there's a myocardial bridge there and it's pretty significant, right? So CT scan is actually really helpful for surgical unroofing. They kind of need this information to know how deep the myocardial bridge is, how long it is, where exactly it is on the artery. And believe it or not, the weird thing is myocardial bridges often happen on the LAD. They're most often on the LAD. So now we have all this information and we're able to say, okay, this patient needs to be unroofed. But unfortunately, I want to show the vasospasm. After the unroofing, the vasospasm was still persistent. So let me get back to that. There we go. This is what I want to show you. So this was several months after unroofing because the patient was still complaining of chest pain. The patient was still having pretty severe episodes that happened at rest again. They're on all the medication they can tolerate because they have hypotension. And so they went and had a post-unroofing coronary function test with acetylcholine, as we learned, and found that they still had significant vasospasm even after the unroofing. Who knows why? Could it be that the myocardial bridge caused such significant endothelial dysfunction that it just went haywire all throughout the coronary arteries? Maybe. We don't know enough about them, which is really unfortunate. But what we do know is that even post-unroofing, this patient has significant vasospasm. So much so that they had to double the medications, even in the presence of severe hypotension. And I'm talking this patient on calcium channel blockers and nitrates had systolic blood pressures in the 70s and 80s for 6 to 8 weeks or so. And at that point, it was just intolerable. This patient can't live like that. So they ended up giving the patient medication to increase blood pressure. This is a corticosteroid called Florinef or fludrocortisone. It is a steroid, but not like prednisone. It's a different kind of steroid. And the patient has to take that medication to increase the blood pressure enough to take the medications needed for vasospasm prevention. Okay, I say all that case study because that patient was me. So mic drop. What? The whole entire reason I dove into INOCA is because I have each and every one of these conditions. Yeah, I gotcha, didn't I? Thank you for that, Selena. I appreciate it. This is me after my unroofing. So I had myocardial bridge unroofing December of last year. My very first symptom was in November. I had exertional angina while I was running. I am a runner. I have run not only several marathons, but I have run ultra marathons. I completed a 100-mile ultra marathon last April, completely fine, asymptomatic. And then 8 months later, had exertional angina on a very slow, easy 3-mile run. As a cardiac nurse, I knew immediately what it was. It came on with exertion. It was relieved with walking. So I walked my happy self back to my car and went straight to the hospital. And what we discovered was positive troponin, positive stress test. And so I ended up in the cath lab by an actual dear friend of mine, a cardiologist I used to work with. And that's when we found my myocardial bridge. Again, 3 weeks later, I actually had a heart attack because of vasospasm associated with this bridge. So we got the sucker out. We removed the myocardial bridge. But unfortunately, I continue to have problems with vasospasm. So I'm on a lot of medications to keep my blood pressure up and to prevent vasospasm. And thank goodness, it's been almost a year since my very first symptom. In fact, it's been about 11 months on the dot. And we have finally found a medication regimen to keep the vasospasms at bay. Now, the benefit of having myocardial bridge unroofing is I no longer have exertional angina. So when I feel well enough to go and run, I can run and perfuse my coronary arteries. My anterior wall of my heart is just fine, even with a higher heart rate. Now, the reason I am pretty passionate about sharing my story is because many HCPs have never even heard of INOCA, let alone the problems that coronary microvascular dysfunction, coronary vasospasm, and myocardial bridging can have. And again, I have all three. My PET scan, what it was picking up was a borderline coronary microvascular dysfunction. So my CFR was 1.8. We know that normal CFR is greater than 2.5. 2 to 2.5 is kind of borderline. So mine was actually pretty bad on my PET scan. And so I have all three. And a lot of physicians, even interventional cardiologists, don't know that these conditions can cause ischemia, infarction, and even death. Excuse me. I'm not getting choked up, I promise. Most patients that present to the ER are told that they don't have any cardiac issues because they don't look like a normal cardiac patient. I am 45 years old. I was 44 when all this happened. Again, I'm a runner. I'm not obese. I don't have hypertension. My lipids were a little off, but they weren't horrible. I think my total cholesterol was 202 and my LDL was 105, I think, maybe. Not super high at all. Again, I don't have any condition. I don't have any health deficits at all. So the fact that this happened was really, really strange, and it kind of stumped us for a while. And even when some tests are positive, like in my case, troponin, most HCPs don't know how to treat patients who have a positive troponin and a normal angio, right? Like, what do you do with that? And then, again, as we talked about earlier, women especially are dismissed. We're told it's stress, anxiety, perimenopause. You got 4 kids, lady. What do you expect? Life is hard. You're just tired. Get more sleep. Here's some sleep medication. Here's some estrogen. Here's some Xanax or Zoloft, whatever. So women are really, we're just dismissed. And it's very unfortunate. Now, the other caveat to that is a lot of trials and studies on medications and medical devices are routinely done on men and men alone. And only very recently have we had the insight to look at women and determine that women, especially in cardiovascular studies, it's not that just we have smaller hearts. Our hearts are different and they function differently than men. It's not just the size, their function is very different. So that's kind of the background of why I am so heavily involved in this. I happen to be a cardiac nurse, and I happen to treat patients like myself. I've seen several myocardial bridges in my career, and I was the one who didn't treat them as importantly as they needed to be. So it's almost my duty to go and make that better. Now, what can you guys do? So now that you know INOCA exists, please help by advocating for advanced diagnostic testing. We know that EKGs and echoes are going to be normal. Lab work's probably going to be normal. Stress test might even be normal. Their angio might even be normal. So please advocate for these new evolving technologies and strategies to measure how functionally significant some of these things are. And recognize that there is a potential bias towards younger patients, women, or those who appear healthy, or those who have minimal risk factors. People look at us and say, there's no way it can be your heart. In fact, I did that myself. When I was running and had exertional angina, I was like, this is weird. It can't be my heart. But I knew enough that I had to rule it out. And guess what? We ruled it in. So recognize those at-risk patients, the patients who come in repeatedly with complaints of chest pain and angina and typical symptoms, but don't look like the typical patient. or don't have positive imaging or lab work or tests or studies or whatever, but continue to come in with complaints of chest pain. Take them seriously and recognize that maybe it's one of these conditions. You can support patient education on symptoms and treatment options, collaborate with cardiology teams, get them up to date, because I promise a lot of them are not. They've not heard about the research that Stanford has done on myocardial bridging. They've not heard about the CORE-MICA trial that has studied these INOCA conditions. Now, granted, in just a couple of weeks, actually, there's a big cardiology conference called Transcatheter Therapeutics, or TCT. It is in California this year, I believe, and they actually do have some coronary microvascular dysfunction sessions, which is great. But what they don't have are any sessions on myocardial bridging or any sessions on vasospasm. And in fact, they don't even cover INOCA. They're specifically looking at coronary microvascular dysfunction. Why? Well, because we have those two devices that we're trialing in the US right now. So really, we need more physicians to understand that INOCA exists and can be very, very detrimental to patients' health and well-being. And then, of course, educate yourselves. Do even more digging on this, especially these three conditions, and educate your colleagues, whether you're working currently taking care of cardiac patients or not. Share this as much as you can so that patients like me who don't have the access to care that I did because I'm in this field, that they can have the same help when they self-advocate. So let's do a fun little game. So I have kind of an interactive Q&A. Myth or fact, and you guys can put this in the question chat if you'd like. So true or false? Myocardial infarction or heart attack can only occur when there is an obstructive lesion within the lumen or of a major coronary artery. Anyone? Bueller typing it? No, it is false. Thank you, Brian and Angie. That is false, 100%. Thank you for paying attention. True or false? Non-invasive tests like blood work, troponin specifically, EKGs, echocardiograms, and stress tests will always show cardiac abnormalities. That's a myth. Very good. Thanks, guys. Completely false. You see where this is going. Oop. If the coronary arteries look normal, the heart is fine. Wrong answer. False. It is a myth. INOCA is rare. Ooh. That's actually false as well. Remember, we talked about 40 to 70% of people that go to the cath lab for a coronary angio complaining of chest pain actually have INOCA. Isn't that insane? Half the people that show up at the cath lab, if they have clean coronary arteries but still complain of chest pain, have INOCA. Myth or fact, true or false, INOCA is benign, meaning non-problematic. You guys know, false. Thank you, Marcia. Thank you, Angie, Brian. Fantastic. It is not benign. INOCA is a chronic ischemic condition with measurable physiological, clinical, and prognostic consequences. That is the only truth on this entire page. If you have to take away anything at all, please understand that this condition can cause severe, severe problems for patients, especially when they're not taken seriously and not diagnosed properly, because proper diagnosis is what's really needed to tailor their treatment, which is mainly medication, to be able to give them what they need without what they don't. In other words, again, with patients with vasospasm, beta blockers is going to be detrimental to them. So if you have someone like me who happens to have myocardial bridging, I did anyway, and vasospasm and microvascular dysfunction, I can't take beta blockers. It'll make the vasospasm worse. So we have to heavy load me on the calcium channel blockers and long-acting nitrates. But the trick with the long-acting nitrates is it sometimes made the MB worse. We had to get rid of the MB first, then treat everything else. But oh no, hypotension. Now we have to give you more meds because you have low blood pressure. So it's super, super tricky to take care of patients. I am not the exception. I am the rule. It is very difficult to medicate and medically manage these patients, especially when they have multiple INOCA conditions. And that's the big takeaway, is you can have more than one for sure. That's what I have. So in conclusion, INOCA requires a nuanced approach to diagnosis and management. 100% the diagnosis is tricky. Increased evidence suggests these conditions are underdiagnosed and therefore undertreated. 100%. You can play a key role in education and patient advocacy. No matter where you are in your career and what you're doing, You will absolutely come across a patient who has this condition. I promise you that. No matter where you end up in your field, where you are now, you will experience a patient as someone who is looking at imaging as an important tool in diagnosis of patients. You will absolutely come across this. I have several suggested resources for some continued learning. INOCA International is a fantastic resource. Now, this is one, they're out of the UK, but if you go online and visit INOCAinternational.com, they have fantastic resources on all of these conditions we've talked about. So that's a good one. International Heart Spasm Alliance is another organization founded out of Europe, I believe, in UK as well. They do have some establishment here in the US, but this is focused generally on vasospasm. They've got a great Facebook group. They have a great website. They've been part of some symposia and congresses, actually just recently in the UK at London, talking specifically about vasospasm. One that I love is a podcast. If you like podcasts, My Imperfect Heart is a great one. I think they're up to episode 50 or 60 now. More than that, for sure. They have interviewed physicians. I'll name a few that I really want you guys to look at if you're interested at all. Dr. Sumit Shah, shout out to him. He's fantastic. He is out of Yale. He is probably the leading interventional cardiologist studying INOCA condition, specifically coronary microvascular dysfunction, but also has a great understanding of myocardial bridging and coronary vasospasm. So this podcast actually interviewed him twice. Really, really great. The second episode that he was on is probably the best one of the entire series. And he talks really, really in great detail about coronary function testing and everything we talked about tonight. There are several surgeons that have been on the podcast as well. Again, this is specifically the My Imperfect Heart podcast is specifically for myocardial bridging. They do branch out into the other INOCA pathologies, but it is an MB specific podcast. So they've interviewed some surgeons, which is fantastic that we got the time from some surgeons. So if you have any interest in myocardial bridging, again, this is just one subtype of INOCA, but I think it's really interesting because we see it a little bit more often because we are able to see it sometimes on angiography. So that podcast is a good one. I highly recommend episode 49 because I'll just let you guys figure out why. Great episode. So that brings us to kind of we're close to the end, and I'd love to take questions and answers, especially because I had the mic drop moment. Selena, I appreciate your comment. I'm glad you're still with us. I am too, for sure. But now knowing that I was a patient, I would love to take any questions from the patient perspective side that you guys perhaps didn't anticipate on joining this presentation tonight.
All right, so yeah, standing by, and Jen, you can take note of the questions box there.
Yeah, I have it open now. If you're too shy to ask questions now, I'm dropping my email here. You can also find me on LinkedIn, but my email is jen.shetler@gmail.com. That's actually my personal email address. I don't mind sharing it with you guys. Definitely find me on LinkedIn because I do share a lot of research on INOCA there. I'm connected to many of the physicians studying. In fact, Dr. Shah is, he's become a good friend of mine. We've been working together to get more awareness on this condition out there. So definitely find me on LinkedIn if this is at all interesting to you. If you have any interest in interventional cardiology, but specifically INOCA, I'd love to connect there because there's a lot of great research happening elsewhere in the world that we are not privy to here in the US. So definitely check me out there. As a cath lab nurse, what was the most surprising aspect to a case as a patient? Ooh, thanks, Kevin. That's a good one. So my first left heart cath was interesting and unique because the physician who performed it was a good friend of mine. He actually was probably the third or the fourth person I called after I had angina. I called a good nurse friend of mine. I called my husband. I think I might have called him third, actually. So it was really interesting to have a cardiac cath done by one of your friends. If you know anything about the access needed to do a cardiac cath, obviously you have access to your artery. So to get access to coronary arteries, you need access in an artery elsewhere in your body. And the two locations that we get access for a left heart cath are the radial artery in your wrist and the femoral artery in your groin. And because we were thinking I had probably a propensity for vasospasm, even with the very first heart cath, we were worried because I'm a smaller sized person. I'm short. So he went femoral. So I had a good friend of mine access my femoral artery during a procedure, which again is in your groin. So that was interesting. The other interesting thing, I know about these procedures. I worked as a cath lab nurse for so long that I didn't want any sedation. Most patients get conscious sedation, medication to help kind of relax you without going under anesthesia. So you still have an airway, you can still breathe, but you're kind of in la-la land. You get a medication called Versed, which is a sedative, and a medication called fentanyl, which is a pain reliever. And you're happy. And I didn't want that because I wanted to look at the images that they were shooting. So I had my first heart cath without any conscious sedation at all, and actually saw my myocardial bridge as they were diagnosing it. It was the image that we saw. As a physician's looking at it, I'm looking at it too. The other interesting component of that was I did have that left main coronary vasospasm that I showed a picture of. It was actually mine. So my left main completely vasospasm, which normally is very dangerous. In fact, mine was so significant, I actually don't know how I didn't have a ventricular dysrhythmia from it. It was very severe. But it was very interesting sensing the change and the shift in the mood of the room because it got very serious very quickly. And I think that's interesting. But yeah, I've had, gosh, how many heart caths now? I've had 3 heart caths. Last November, this past May, and this past August. August was my coronary function testing. So yeah, I've had a lot in the last year. Richard says, after CE presentation, dialogue may be great. Yeah, I agree, which is why I really would recommend you guys linking up with me on LinkedIn, because I would love to continue to dialogue and chat more about this. So please do connect with me on LinkedIn or drop me an email if you'd care to know more, because I would love to continue the discussion, especially if you have any interest in this at all. It really makes me happy knowing that there are healthcare providers out there who will take this condition seriously and maybe change someone's life because they know about it versus not knowing about it. Richard wants to boycott the question box.
No, Richard, don't do that.
Don't do that.
All right, Jen, let's wrap it up and call it a day for this presentation.
Excellent. Well, I am done. So I appreciate all of you guys for sticking with us for so long. I hope it was worth your time. But yeah, I'm really glad you guys had an interest in this presentation. Probably many of you, without even knowing what INOCA meant, signed up for this presentation. So thank you for paying attention, and I appreciate the invitation to be here.
Hey, Jen, thank you so much. And on behalf of Nicole and myself, we are certainly happy to hear after a year that you're doing great, and we wish you all the best.
Thank you so much.
All right, Jen, thank you so much for your time. We certainly do appreciate you. Thank you so much. Do have a wonderful evening. All right, everybody, quick reminder, you must complete the survey to receive your certificate this evening. Check your email. The speaker survey will be in your email. If you don't see it, check your junk folder. And if it's still not there, shoot me a text on email and I will forward that to you. Certificates will be emailed within 24 hours. Thank you, everyone, for attending today's webinar. Thank you, Jen, for your presentations. We certainly do appreciate all of you. This is South Texas Associates of Radiology. Do have a wonderful evening, everyone. We'll see you on the next webinar.